of us are on, take a photo, click. We never do that in any of ARC.
I'll do that now. सबको screen on कीजिए तो. I'm taking it now.
We are live.
A very good evening to one and all of you. We are back to all of you again with this update series on oculoplasty, but with a difference. And we look forward to a great information transfer and participation, of course. We are lucky to have the top cream of oculoplasty surgeons with us on the expert panel on this webinar. We have with us Dr. Usha Kim, who's the Chief Consultant Orbit and Oculoplasty Services at Arvind Eye Care Systems, Madurai. We have Dr. Milind Naik, Consultant Ophthalmic Plastic Surgeon, LV Prasad Eye Institute, Hyderabad. Dr. Lakshmi Mahesh, Oculoplasty Consultant at Manipal Group of Hospitals, Bangalore. Dr. Ravindra Mohan, leading Oculoplasty Services, Chennai, to keep us all energized through the course of this webinar. I have Dr. Shruti Tara, Consultant Oculoplasty from Shankara Group of Hospitals, Coimbatore, and Dr. Satyajit Sinha, who is a member ARC East Zone, and also the MD of the ABI Institute, Patna, moderating along with me. So we shall now go on to our first speaker, who is none other than our esteemed, very versatile surgeon, Dr. Swati Kalki, who is the head of OEU Institute of Eye Cancer, head of Oculoplasty Services, LV Prasad Eye Institute, and she is going to dwell on something very relevant and novel and interesting, the current status of targeted therapy for locally advanced periocular malignancy. On to you, Dr. Swati.
Thank you very much, Dr. Chitra, and everyone who have organized this wonderful meeting today. Very good evening to all of those who have joined us. I'm going to share my screen now. Yeah, so I'm going to talk about the current status of targeted therapy for locally advanced periocular malignancy. I do not have any financial disclosures to make, and there will be certain clinical photographs that have been used in this presentation, and appropriate permission has been obtained for the use of the same. Now, whenever we come to a oculoplasty clinic or specifically oncology practice, we do see quite a few eyelid malignancies. And eyelid malignancies, when they are small like this, be it basal cell carcinoma, squamous cell carcinoma, melanoma, or sebaceous gland carcinoma, we can easily excise them and give them appropriate cosmetic results where the tumor also has been taken care of and appropriate cosmesis has been provided for the patients. But rarely we do see malignancies like this, where it is in very, very advanced stage beyond the surgical resection. Virtually, it's almost like inoperable cases. In such cases, what do we do in them? Also, we see cases where there is syndromic association, where there is multifocal lesions. For example, in this lady, where you can see that there are multiple basal cell carcinomas that you can see, one affecting the right eye, of course, and multiple areas over the face as well, and also in the periauricular area. So these cases are very, very difficult to manage. And that's when the targeted therapy is actually important in these cases. Now, with advances in the ocular oncology, there is a new paradigm treatment that is now available, that is the targeted therapy. Basically, what is targeted therapy? That is, these are the treatments which work on the molecular pathways of these tumors, and they target and interfere with the cellular signaling pathways. Thus, they take care of the cell, they inhibit the cell proliferation in these tumors, thus helping in cure of these tumors. Now, let's take each tumor one by one. We'll start off with basal cell carcinoma, for the reason that great advancements have been made in basal cell carcinoma compared to other tumors. Now, when we talk about basal cell carcinoma, I think it is very, very important to know that this fly called the fruit fly or the Drosophila melanogaster is one which actually, the experiments on this fly have actually revolutionized the treatment that is available today. So it was in this fly in 1980s when it was detected that there is the hedgehog gene that is present, which is very, very important in cell proliferation, which when inhibited can cause adverse effects, or when activated rather causes adverse effects. So what is the hedgehog genes? So basically the hedgehog gene, which was first detected in the fruit fly, later it was detected in vertebrates. 3 different hedgehog genes were identified. The most important of it is the sonic hedgehog. Now, sonic hedgehog signaling pathway is very, very important. It is present in many cells, and it is important for the embryologic development of many systems like the neural tube, the musculoskeletal system, the hemopoietic system, and skin as well. It takes care, it controls the cell cycle regulation and maintenance of the progenitor cells. And when there is activation of the sonic hedgehog pathway, it causes many solid tumors, one of which is basal cell carcinoma. So what happens when the cell is normal? So when the cell is normal, now there is a cell membrane protein called as patched 1, which is in green, which is in blue there, which is now circled in red. That is the cell membrane, the transmembrane protein that is present. It acts to inhibit the other cell membrane protein called as smoothed. So when there is inhibition of this smoothed, it inhibits the transfer of this protein into the cell and thus prevents the activation of GLI proteins, that is the glioma associated oncogenes proteins which are present, which when activated can cause proliferation of various transcriptomes. Now, what happens when in BC or in many solid tumors, including the basal cell carcinoma, is that is when there is no inhibition. So the sonic hedgehog genes, they inhibit the transmembrane protein, that is the patched 1. So when that is inhibited, this in turn, it cannot inhibit the function of the smoothed transmembrane protein that is there. And when this is not inhibited, it gets into the cell and it activates the GLI proteins. And this in turn, it causes many changes inside the cell, which can cause cell proliferation and ultimately the tumors. Now, this is an example of a case of nevoid basal cell carcinoma, or also called as the Gorlin-Gault syndrome. So it is an autosomal dominant syndrome where multiple basal cell carcinomas are present, as you can see in this picture. And they also have dyskeratotic palmar and plantar pitting along with odontogenic keratocysts. Now, this is the same patient where you can see multiple BCCs that are present, and he also had the dental changes that are associated in this patient. Now, to treat this patient, if it was only the eyelid lesion or if there were a limited number of tumors, it's easier to treat. But when there are multiple throughout the body, not just on the face, it is very, very difficult. And also a long time, they develop many tumors. Now, what actually happens in this syndrome? So in this syndrome, there is mutation of the long arm of chromosome on the patched 1 gene that we just mentioned about in the sonic hedgehog signaling pathway. So when that is mutated, so this is obviously inhibited and this gets activated, and also the GLI proteins are activated, which in turn results in activation of the sonic hedgehog signaling pathway. Now, what is the targeted therapy? So once now that we have understood the pathogenesis of basal cell carcinoma, now it is also important to understand that this the sonic hedgehog signaling pathway activation not only happens in the syndromic association of basal cell carcinoma, but also in sporadic cases. It has been shown that 70 to 80% of sporadic cases of basal cell carcinoma also have the activation of the signaling pathway. So if we have to have a targeted therapy for basal cell carcinoma, it has to target the sonic hedgehog signaling pathway. And this may not be required in all cases, because when it is small, it can be easily excised. But when it is locally advanced, or if it is refractory to other forms of treatment, or if it is a metastatic disease, or in inoperable cases, then targeted therapy for the basal cell carcinoma is very, very useful. Now, I'm sure many of us have heard this terminology in many meetings where it has certainly made a splash, where it is the vismodegib. It is a small molecule treatment for basal cell carcinoma. It basically targets and it inhibits the smooth protein, that is the transmembrane protein that is present on the cells. And when this is inhibited, it prevents the entry of this into the cell, and thus there is no activation of the gli proteins, and there is no other changes that occur in the cell. It basically inhibits the sonic hedgehog signaling pathway. Now, this drug has been approved for use of basal cell carcinoma in very advanced cases in the year 2012, and it is given at a dose of 150 milligram once daily. This was the phase 1 clinical trial, which was first done in 2009, where 33 patients were enrolled in this study, and it was shown that 2 patients actually had complete response with this drug, and 16 patients had partial response, and 11 patients had stable disease, but about 4 patients had progressive disease. So it's not that it is useful in every case, but certainly in inoperable cases, in almost about 50% of the cases, it is useful. Now, these are the pictures from the same paper. This was the first, the phase 1 trial, where they have shown that it is effective. Then came the phase 2 trial, which was done in 2012 to establish the efficacy and the safety of this drug for use in advanced basal cell carcinoma. In this, about 96 patients were enrolled, 63 of them with locally advanced inoperable basal cell carcinomas, and 33 with metastatic disease. And it was seen that there was a reasonable response rate, with 43% response in locally advanced tumors, and in 30% of the cases with metastatic basal cell carcinoma. But it is important to note that almost 12% of them had to discontinue the treatment because of the side effects, where the major side effects that occur are the muscle cramps and all the other side effects similar to any chemotherapeutic agent, like loss of appetite, loss of taste, alopecia, and all that. But the most important was the muscle cramps, which caused discontinuation of treatment in 12% of the cases. And 7% of them died, but whether the death is because of the drug could not be established. These are some of the pictures from the phase 2 trial study, where it can be seen that there is definitely very good response with this drug, and these patients did not require any treatment. Then that was being used for cutaneous basal cell carcinoma. And then the next study came in where it was used for basal cell Nevis syndrome. And in this, again, it enrolled about 41 patients. And it was seen that when vismodegib was given versus a placebo, these patients had lesser chances of developing newer BCCs and thus requiring fewer surgeries and reduced burden of surgically eligible BCCs. However, 54% of them had to discontinue treatment because of severe side effects. And the other very important thing to note was that the tumors regrew when the drug was stopped. So which means that the drug had to be continued if the tumors had to be kept under control. And these are the pictures from the same paper, where it can be seen that there are definitely impressive results with the total disappearance of the lesions. Then it was used for periocular basal cell carcinoma. So from the year 2012, there have been numerous papers which have used vismodegib for the advanced periocular basal cell carcinoma. And here are a few examples where there is good response with this drug. So the advantages that have been described are that it obviates the need for surgery, the need for extensive surgical intervention, and the need for exenteration in few cases. But it has not become very popular in regular practice because of the high cost, because you can see that the cost is almost, in the US, it is about $7,500 per month, which means almost about 4 to 5 lakhs in Indian currency. Then they have high toxicity. The long-term treatment is required, which means lifelong treatment may be required. And some of them even develop new carcinomas, new squamous cell carcinomas. So that's about the basal cell carcinoma. Moving on to squamous cell carcinoma. Now, squamous cell carcinoma, the pathogenesis of squamous cell carcinoma is the inactivation of the inactivating mutations in p53 gene and mutations in EGFR. So it is noted that there is overexpression of EGFR in squamous cell carcinomas. So the targeted therapy that has been tried for squamous cell carcinomas are the EGFR inhibitors, namely the erlotinib and the cetuximab. However, this again has limitations that it is associated with high cost, about 3,000 per month. It has adverse effects and there is lack of long-term follow-up. And thus, again, it has not been used in clinical practice and it is still in the clinical trial stage. Then for malignant melanoma, the pathogenesis of this is that, again, there is inactivating mutation of p53 gene, and there are mutations of the proteins in MAPK pathway. So MAPK pathway is a series of proteins where it's a chain of proteins which actually it passes on the signal from the surface receptors to the DNA which is present inside the nucleus. And there are various proteins that are involved, that is the RAS, RAF, specifically the BRAF, the BRAF and MEK and ERK pathway. And it has been shown that BRAF is present in about 66% cases of malignant melanoma and RAS in about 15 to 20%. And the targeted therapy that has been used for these cases is the BRAF inhibitors have been used and also the MEK inhibitors. However, the limitations are that the drug resistance occurs, especially if only BRAF inhibitors are used, and they can also develop new squamous cell carcinomas, and which can disappear or they involute once this drug is stopped. However, the new squamous cell carcinomas are less likely to develop if it is a combination treatment between BRAF and MEK inhibitors. And it also has adverse effects, and we do not have long-term follow-up for the same. Lastly, about the sebaceous gland carcinoma. Now, the exact pathogenesis of sebaceous gland carcinoma is not known. Mostly it arises de novo. But however, because in Muir-Torre syndrome, there is association with multifocal sebaceous gland carcinomas that can occur, probably it could be related to the MMR gene mutation, even when it is not associated with the syndrome. And there is also inactivating mutations of p53 gene. And it has been shown that there is upregulation, there is overexpression of EGFR. Yeah, I'm almost done. And also there could be activation of hedgehog pathways. Targeted therapy for sebaceous gland carcinoma, it has not been tried yet. So there are no drug trials yet in this. So based on these, we understand that it is important to understand the pathogenesis of eyelid tumors, to understand about the molecular therapies for these eyelid malignancies, and which could improve outcomes in inoperable cases. So that's all I had for my talk. Thank you very much for your time.
Thank you very much, Dr. Swati. It was so interesting and informative. I'll ask one simple question before I ask Swati to take on. That from what I heard you, is it reserved only for non-resectable tumors, or do you think it is replacing the surgical treatment modality in ocular oncology per se?
No. So even now, yeah.
Thanks.
Yeah. So even now, if it is a resectable tumor, then surgery is the treatment of choice. These drugs are reserved only for inoperable cases or metastatic disease. And also because of the high cost, it is not in routine clinical practice as yet. But I think, yes, it is important for all of us to know about them, because maybe 10 years or 20 years down the line, it may become standard of care. But at this point of time, it is used only for locally advanced cases.
Dr. Swati?
Thank you, Dr. Swati. That was a really something that we should consider probably over time, as you said. As of now, that it is really so expensive that I don't know how much of us can actually put it across to our patients for as a treatment, even in non-resectable cases. Have you had any experiences using them in your practice?
No. So when I was in the US, I have seen a couple of cases where definitely it's like very impressive results. but also the side effect, the side effect profile is really, really high. And if the patient has to take that lifelong with these side effects, it's like, really difficult. But here, no, I don't think in India anybody has used these drugs. But yes, in the US, I have seen a couple of patients.
So each of these, like even if you use them on a to reduce or chemo reduce like a chemo reduction basically, even after you resect them, do you still have to continue this medication, or you need to?
So if it is a single tumor and if you have used it only as a neoadjuvant therapy, then you don't have to continue it like neoadjuvant, and then you have done surgery or radiation and then you don't have to continue it. But most of the times, especially the vismodegib, it is used in the syndromic association patients. And in them, it is mainly to prevent the new tumors and take care of the existing tumors as well. So there it becomes a little tricky, because even if you have surgically resected the tumors that are present, but in order to prevent the new tumors, you may have to continue for long.
For long. Okay.
Yeah.
And then keep them on a regular follow-up to see if there's any recurrence.
Correct.
Has anybody in the panel got anything to add?
Yeah. Expert panel.
Ma'am, Milind
wants to take it.
Okay. In the meanwhile, you want to say, ma'am?
No, it's a great talk, and I think it's the need of the hour, but we have a lot of work to do before we start advocating this, considering the cost factor. So that's all I think we have.
Thank you, ma'am. We'll move on to the next speaker now. It's an honor and privilege to welcome Dr. Vijay Rangarajan, who is Chief of Orbit and Oculoplasty at Arvind Eye Care Systems in Coimbatore. She will be talking on oculoplastic factor in cataract surgery, an interesting aspect to know. A very warm welcome to Dr. Vijay Rangarajan, please.
Thank you, sir. Slides.
Can you share the screen, ma'am?
Yes, sir. Are the slides seen, sir?
Yes, ma'am.
Yes.
Okay.
You're good to go.
Yeah. So today I'll be speaking on the oculoplastic factor in cataract surgery. So as ophthalmologists, our main concern is cataracts. And as cataract surgeons, our main concern is to give the best visual outcome. And we have to take every small step to bring the best visual outcome for the patients. So while examining a potential cataract patient, we focus mainly on condition of the cornea to see if there's any corneal dystrophy, on the condition of the lens to see if there's any zonular weakness or any pseudoexfoliation, and also check the retina so that we don't get any surprises later due to macular degeneration and any other retinal problem. But condition of the lids and tear ducts are often neglected. So it has to be borne in mind that ocular adnexa can also affect the outcome of cataract surgery, because post-cataract endophthalmitis is the worst nightmare of any cataract surgery. So I'll be dealing with some of the case scenarios which we encounter in day-to-day life, and what we should do when we come across these cases and when we have to refer them to the oculoplastic surgeon. So most common cause of postponement of cataract surgery is blepharitis. 60% of adult patients or elderly patients have blepharitis. So this blepharitis can be anterior or ulcerative, and or it can be seborrheic or squamous. So the problem with this case is this condition is it can cause tear film instability, dry eye, corneal punctate erosions, and corneal ulcer. So you can see here, this is a posterior blepharitis is caused by Meibomian gland disease or Meibomian gland dysfunction. So here you can see the Meibomian glands is oil globules and also foamy secretions. So this can lead to recurrent chalazion and also corneal punctate epithelial erosion. So you can see this patient, she's got a cataract, but at the same time, she's got on the periphery some amount of marginal keratitis also. and also congestion of the conjunctiva. So the problem with these conditions is the issues which are faced mainly by the patient is after the cataract surgery, the eye is constantly irritated. There is a longer duration of inflammation, and there's a poor visual acuity after cataract surgery, and also there's a great risk of post-op endophthalmitis. So the treatment would be warm compress and lid hygiene, antibiotic ointment or antibiotic with mild steroid, artificial tears to alleviate dry eye, and oral doxycycline 100 milligram can be given daily, twice a day for 1 week, and then it needs to be given daily once for 6 to 12 weeks in recalcitrant cases. So the time interval before performing cataract surgery is we have to wait at least for 21 days after starting the treatment, do a bacterial culture from conjunctiva, and start pre-operative topical antibiotics at least 1 week prior to cataract surgery. The next common condition is theriasis palpebrarum, and this is caused by crab louse or very rarely head louse and affects people living in poor hygienic condition. This condition also can cause chronic irritation and itching. Here the treatment would be trimming of the lashes at the base and mechanical removal of the lice and lashes. And next, third condition is atopic dermatitis or eczema. So you can see here, it's a bilateral but asymmetrical. They have vertical fissuring of the skin with pigmentation, and also and also the patient has got a mild ectropion here. So this condition is idiopathic and associated with hay fever, asthma, and also commonly it is associated with a generalized dermatitis. Affecting the eyes alone is very rare. Signs are periorbital darkening, thickening, crusting, and loss of lashes and blepharitis and chronic conjunctivitis. And we can treat this patient with a topical steroid and emollients to hydrate the skin and oral antihistamines. The importance of treating this condition before a cataract surgery is we have to treat the associated infection like blepharitis and chronic conjunctivitis. Another common condition is chalazion. It's a chronic sterile granulomatous inflammatory lesion of the lids. So you can see here this it's a quite large chalazion, and here it's a small one at the lateral aspect, and you can and another chalazion which is secondarily infected with staphylococcal infection of the Meibleman glands is called as internal hardiolum. This causes a tender swelling and it can discharge through the skin or the conjunctiva. And an external hardiolum, which is an acute staphylococcal infection of the lash follicle or the glands of Zeiss, which presents a tender swelling at the lid margin. So the treatment would be hot compress to alleviate the pain, topical and systemic antibiotics, epilation of the affected lash root to allow drainage of the pus, and non-resolving chalazion, we can do an incision and curettage. So what is the time interval before performing a cataract surgery? So mostly since chalazion is a sterile granulomatous inflammation, whether we should perform whether we should do an INC or not is a debate, but it is prudent to wait at least for 7 days after complete resolution of the chalazion and do a conjunctival culture and also give pre-op topical antibiotics before performing a cataract surgery. And other common conditions which we encounter day to day is lid position abnormalities like ptosis. So here this patient has got a mild ptosis which is not affecting the visual axis, and this patient has got a left eye moderate ptosis which is partially obscuring the visual axis. And again, this is again a mild ptosis which is not obscuring a visual axis. So this is a case where the patients have got severe or a complete ptosis, and this patient has got moderate to severe, just again obscuring the visual axis. So again, whether we have to do the cataract surgery first or deal with the ptosis. Mild ptosis is just a cosmetic problem. So that in these cases, the cataract surgery can be done first. And with the ptosis obscuring the visual axis, fix the ptosis first and alert the patient of existing ptosis, because most of the time when the patient has got a cataract, they would not have noticed a subtle ptosis which has been present pre-op. So once the vision improves, they will blame the surgeon saying that after the cataract surgery, the ptosis has worsened. But in fact, 1% of cataract surgeries can actually worsen the ptosis because of speculum and manipulation of the eyelids. So it's very important to tell the patient pre-op if the patient has got a mild ptosis. And all patients, before doing a ptosis correction, check for dry eye status and Schimmer's test. Routinely abroad, many surgeons do above 50 years. They do a Schimmer's test for all the patients who have ptosis. And another condition which we see in elderly patients is this dermatochalasis. Here you can see a patient has got a very loose, baggy skin, bilateral condition. And here the, yeah, and see on raising the lids, you can see that lid is in normal position, and this patient has got a in the left eye a lateral droop or a lax lid. Here, the redundant upper lid skin is very heavy and they lie on the top of the lashes, which creates a warm, sticky environment, which is favorable for blepharitis, especially in thin skins. In the the white people, they have very thin skin. So in those people, blepharitis is very common in patients who have dermatochalasis. So the treatment, we have to refer these patients to oculoplasty surgeon for blepharoplasty. And again, ectropion, this is another common condition which we see. And here you can see the patient has got a generalized ectropion, and you can see so much of congestion and the corneal involvement. And sometimes the patient can have here, he's got a right eye of a medial ectropion, and there's a very mild generalized ectropion in the left eye. And this is a tarsal ectropion. So, and next condition, another important is inversion of the lid, that is an entropion. Here you can see this, sorry, the lid is turned inwards here, and also here. And these patients can have, again, entropion can cause pseudotrichosis and corneal involvement, and also secondary infection. So to diagnose these conditions, you can do a simple test, which is called as a snapback test. Here, the lower lid is distected downwards from the globe and released. Normal lid will snap back or spring back immediately on release. And if the snapback test is positive, you can do a lid tightening procedure prior to cataract surgery. And another condition we encounter, and many times we miss it, is trichosis. Here, this patient, she is here you can see the lower lid. This is a very mild 2-3 lashes, but here she's got slightly more lashes which are they're misdirected and touching the cornea. And if the patient has got a mature cataract and only trichosis without any lid abnormality, you can do an epilation or radiofrequency. But if there is an entropion associated with trichosis, then corneal health is a compromise. So plan for entropion correction. And if the lashes are pointing down, always suspect a floppy eyelid syndrome. So this patient came to us with chronic, like he could not open the lids. He had severe blepharospasm, and here the lids were irritated. So he came inside the OPD by tying a kerchief around the lids. And you can see on everting the lids, there's a chronic papillary conjunctivitis. This can be bilateral or unilateral. And these patients always, they have a habit of sleeping prone on the pillow, which causes the lid to evert, and they also have a sleep apnea. So ask the spouse whether the patient snores in the night. And so this can be treated by doing a pentagon resection of the lid before the cataract surgery to stabilize the eyelid and ocular surface to prevent nocturnal lag of ophthalmos and exposure keratitis. And next condition is the lag of ophthalmos. This could be due to facial palsy. And here again, you can, or it could be sometimes only nocturnal mild lag of ophthalmos. Here, this patient has got lag of ophthalmos with a good bells. And this patient has got a moderate bells. And here you can see in this patient, the bells is very poor with the complete exposure of the cornea. And we need, these patients should definitely be reduced to referred to oculoplastic surgeon to do a procedure that will reduce the horizontal and vertical dimension of the palpable aperture before cataract surgery to prevent exposure keratopathy, epiphora, and corneal infection. Lacrimal abnormalities, again, canaliclitis. This is caused by actinomyces israeli, and here you can diagnose easily by noticing a pouting punctum, which gives a diagnostic clue, and also there will be a pericanalicular inflammation. So treatment would be canaliculotomy and topical antibiotic for 2 weeks prior to cataract surgery. And dacryocystitis, again here you can see this patient has got a mature cataract, but there's a pus discharge. And this patient was a one-eyed patient, but she did not have a pus discharge. She just had a mild watering. And here you can see there's a cataract, but the patient again has got a raised tear meniscus. What is very important is always do a syringing prior to cataract surgery. If there's a punctal stenosis, cataract surgery can be undertaken. And if the syringing is free, look for other causes of watering, like either a medial ectropion or dry eye. If the patient has got not free with clear fluid but mature cataract, cataract surgery can be done after the conjunctival culture and sensitivity and after giving a topical antibiotic for a couple of weeks. And again, if there is a nuclear sclerosis grade 2 or there is a mucopurulent discharge, then SAC surgery has to be done before cataract operation. So, and lastly, malignant lesions, lid lesions. Here, there you can see there is subtle ulceration of the lid, and this also looks like just like some inflammation. And this is like a small chalazion, and and this looks. The patient told that this is present for many years, and he said it's like a nevus, and then this. Here you can see there's a ulceration of the skin with it's like a rodent ulcer. This is again a small meibomian gland carcinoma, and the patient here has got a cataract as well. And these are frequently misdiagnosed because they're treated as inflammation or blepharitis, but blepharitis can never be unilateral or affecting only one small portion of the lid or only one eyelid. So it is usually bilateral. So proper history has to be taken as to the duration or whether there's any ulceration, any bleeding from the lesion. Look at the lashes and see whether there are any loss of lashes at that involved area or any distortion of the lid margin. And why we need to address this malignant lid lesion before cataract surgery is because we use a speculum before doing the cataract surgery. This can dislodge and cause spread of the tumor cells. So take home message, strategies for successful cataract surgery is never overlook the eyelids. Don't assume that oculoplastic issues can be addressed after the cataract surgery. If something is isn't quite right, don't let it drop. If you have any doubt, if the cataract surgeon is having any doubt, kindly refer the patient to an oculoplasty surgeon, because he may be dealing daily only with a cataract surgery and may not notice any subtle differences in eyelid lesion, which an oculoplasty surgeon can pick it up as soon as he sees the case. Inform the patient of the consequences of the procedure, like especially when the patient has got a very mild ectropion, we can do the ectropion surgery later. Or if the patient has got only watering and no discharge from the eye and is not willing to undergo the oculoplasty procedure, wants to address the cataract surgery first, then we can take up the surgery. We can take the patient for cataract surgery after giving antibiotic drops for 2 weeks. And so we have to inform the patient of the consequences and then reconsider. We have done many cases like that, and where we have not had infection also. And never hesitate to refer the patient to oculoplasty surgeon if there is any doubt. Thank you.
Thank you, Dr. Vijay. That was amazing talk and full of clinical photos, very interesting. So I have a question to you and Dr. Usha, any of you could take it. So when you talk of ptosis and cataract surgery, we understand that it is going to have a topographic and a keratometric impact because of the ptosis. So probably a with the rule astigmatism. So what should a cataract surgeon know when there is a ptosis about doing cataract surgery, how it can impact the biometry?
Want to take it?
Vijay or Usha?
Yeah.
Actually, madam, in old patients, there's not much impact on the refraction or anything. It's only mainly in children where there is, they can have astigmatism or amblyopia or any refractive error. but not in a senile or involutional ptosis. So condition like ptosis can be addressed even after cataract surgery, unlike entropion or ectropion. But yeah.
Only word of caution here would be to keep the patient aware that there is a ptosis.
Yes.
Because often it's attributed to the cataract surgery. The presence of ptosis has to be informed to the patient prior to the surgery. And if it's in the if it's obstructing the visual axis, that also has to be made aware. When do you want to do the ptosis surgery is absolutely left to the patient as well as the surgeon. But what is necessary is to keep the patient informed. That's one thing I think. And as Vijay has pointed out, it's the stiff lids which can cause astigmatism. So I think the early lids, probably the early age can cause astigmatism, and especially if it's moderate to severe.
So when the patient comes to you, has lived with the ptosis and comes to you at a point when he needs a cataract surgery, probably a gap of 3 months would be ideal. Do the ptosis correction and then address the cataract, because your IOL-ARC calculation would be more accurate because you've done away with the astigmatism caused by the ptosis.
Actually, there's not much of an astigmatism caused in the older lids. It's usually the younger ones which cause an astigmatism. And often it's not necessary to hold it for 3 months. You can actually do it right after. In fact, most of us do it a week later or about 15 days later. So I don't think we need to wait. I'm sure the panelists on the, I think agree, because I can see them nodding. So Dr. Lakshmi, Ravindra Mohan and Milind, most of them are nodding. So I'm assuming that all of us are on the same page with regards to doing the cataract surgery post-ptosis correction.
I have 2 comments. One is, of course, if it's mild, I think we like to finish the cataract first. But if it's severe, of course, you have to go ahead with the ptosis correction. Now, the large series what Vijay showed, many of the patients had a saddle nose with mudderosis. I'm not sure whether there are pockets of Hansen's there. And in cases of Hansen's, one warning, the only 2 endophthalmitis I had in the cataract career of 15 years was a case of Hansen's. 10 years later, again a cataract surgery was done, and again he developed an endophthalmitis. He landed up with bilateral evisceration. So dermatologist gives the clearance and all that. I think we have to, when we see mudderosis and such a saddle nose, I think we have to keep in mind and pep up the antibiotics and things. I don't think a routine follow-up will be sufficient for such case.
Yeah. One more point I really like to emphasize is, please advocate syringing, because we often think that it's a redundant procedure and just a row plus is adequate. I plead the audience and also the people in the forum to continue with the syringing, because it's a very, very important test, and it gives you the idea as to manage the case appropriately. A row plus will just give you plus or minus, but it doesn't give what is the actual status of the passage. So I'm sure everybody is in agreement. If not, please give your suggestions.
In Hansen's, you can have row plus negative and it can be fine, but there could be a component of reaction, erythema, nodosum, leprosum. It can be a late end of. That's why we have to follow them up very carefully.
Dr. Milind has got something to say.
Yes.
Yeah, regarding the row plus, I remember an excellent paper by Ravi Thomas where he mentions that if your row plus is negative, you better recheck it with syringing. But obviously, if you find it positive, then it's diagnostic.
So which eventually means that we have to do a syringing.
Yeah, correct.
Yeah.
And even if the syringing is, if it is clear fluid regurgitation, would you still recommend a cataract surgery in these patients, or would you go ahead with DCR and then later on cataract surgery?
This is again a very valid question and a very valuable question, because often we think that it's only the cataract which is causing the visual deficit. It could be just a tear film also causing a visual deficit. So if patients are very concerned about the visual loss because of the tear film, I think it's appropriate for us to perform the DCR surgery, because that's causing a visual deprivation in any case. So
And if there is a common canalicular obstruction, like see, suppose when you're doing a syringing and you see it is a soft stop and it is a common canalicular obstruction, then it is safer to, this is if the patient has not had any DCT done.
exactly.
A simple CC block, what would be your way of handling it? Would you take a culture and then go ahead and do it, or you can straight away go ahead and do the cataract surgery? What would you recommend?
No, I think a culture would be a good idea because you need to also keep the safety factor in mind. We don't want to push towards feeling good about it. We also want to make sure that everything system is all right. So I would definitely recommend a culture.
Thank you, Dr. Vishay.
Dr. Ravindra Mohan, please. Sir, we can't hear you.
Mohan, I think you are muted. Can you just unmute?
Sir, we can't hear you, sir.
Has he unmuted?
He has unmuted, but we can still not hear it.
Okay. So shall we go on to our next speaker?
Dr. Milind.
Dr. Milind?
Yeah, just one comment. I would like to really commend Vijay for a very relevant talk. It was fantastic. And I just wanted to add 2 points. One is sometimes you can have patients with spasm and cataract. And usually you can give a facial block and manage the surgery per se. But it's always good to Botox them and a couple of weeks down the line operate, because that can always increase the intraocular pressure with spasm.
Yes.
And a very rare phenomenon is called thyroid eye disease reactivation. So these could be patients who've just had mild to moderate thyroid eye disease. Now they are inactive. And cataract surgery is one of the commonest reasons why their disease activity can reactivate decades after their thyroid has been stabilized. So in these patients, it's important to tell them about this very rare possibility. Thank you.
And Dr. Milind, would you, if it is said that if you give a block is when the thyroid gets reactivated, does it happen even with topical?
There is no data about topical, but when they looked at what reactivates it, any periocular surgery in future. And obviously, statistically, cataract is the commonest thing, so it came out as the most obvious.
Thank you. That was great information. So we shall now move back to basics. And our first speaker in this segment is our dynamic Dr. Marian Pauly, who will be dwelling on MMCR. And she's a senior consultant, Department of Orbit and Ocuplasty, Giridhar Eye Institute, Cochin. So let's hear from you, Doctor.
Hope I'm audible.
Yeah.
At the outset, let me thank AIOS for giving me this opportunity. A few words about the anatomy. Aspero-Muller's muscle is a symbiotically innervated muscle that arises from the undersurface of levator aponeurosis at the level of Litnow's ligament, and it inserts the superior tarsal border.
Share your screen, please.
Sorry?
You have to share your screen.
Yeah. Sorry.
No
So
problem.
what are
Can
the
you make the
indications?
screen, please? Good. Go ahead.
Hope the slides are seen now.
Yes, please go ahead.
So the indications are mild to moderate ptosis with good levator function, that is more than 10 millimeters, and the phenylephrine test is positive. Coming to the surgery proper, the surgery is done under frontal nerve block with subconjunctival infiltration. The traditional MMCR is described by Putterman and Urist in 1975, where we are removing Muller's muscle and conjunctiva. It turned out as a modification of fascicular cervite procedure, where in fascicular cervite we are removing a 3 millimeter of tarsus also. So in this technique, which I am going to show, I am doing an isolated Muller's muscle dissection by sparing the conjunctiva. So this is a video with audio in between.
Post-lid crease incision is marked and traction sutures are taken corresponding to the pupillary plane, medial limbus and lateral limbus. Eyelid is everted over Desmaides retractor. conjunctiva is incised with radio frequency cautery. Dissection done to separate conjunctiva from the Muller's muscle with Westcott scissors and cotton-tipped applicators. Care should be taken not to create any buttonholes in the conjunctiva during the dissection. Now Muller's muscle is separated from the superior border of the tarsus with Westcott scissors. Now Muller's is separate from the conjunctiva and levator aponeurosis. We can see the white line of levator aponeurosis in this. Resection of Muller's muscle is done with radiofrequency cautery. Initial resection, the Muller's muscle stump is secured with the help of 6-0 catgut sutures. Section is completed with the help of radiofrequency cautery and scissors. The resected stump can be sent for histopathological examination. The stump is attached to the superior border of the tarsus with the help of sutures. Three such sutures are taken.
1 minute.
And the sutures should come out through the skin through the proposed lid crease. The sutures can be either 6-0 catgut or 6-0 silk or 6-0 prolene. The non-absorbable sutures has to be removed at the end of 2 weeks. Conjunctiva is sutured with 7-0 Vicryl, or we can use glue in this stage.
Time.
So once conjunctiva is closed, the wound is tightened and bandaged contact lens is put. So the post-op care, we can give topical lubricants and antibiotics. If non-absorbable sutures, remove the suture at 2 weeks. And you will get a very good post-operative results. These are a few post-op pictures. Complications very rare if it is properly selected case. Thank you.
That was very nice and crisp talk, Dr. Marian. So we understand that the response to the topical analysis test is critical to plan on the amount of resection and the surgical outcome, right?
Yeah.
So Dr. Shruti, can you ask a question?
That was a very nice talk, Dr. Marian. Dr. Ravindra Mohan, sir, do you have anything to comment on?
Yeah. I'm sorry, I was shifting from one device to the other. I so missed it. I have some questions which I'll ask maybe later.
Dr. Milan, do you have any question to ask?
No, I'm fine. I loved it.
We'll move on to the next speaker now. We have.
I have a question for Marian.
Yes.
Marian, what's the main criterion for doing this? Now,
Mild
what happens to the mullahs after you resect? The levator edge will recede back. It will worsen the ptosis, right?
No, ma'am.
And do you find such a nice and thick mullahs all the time?
Yeah,
Unless, of course, case of thyroid or something like that.
probably my case
Generally,
selection is very
muscle, no? Huh?
very predicted results and no complications. Patients are very happy, and it's all patient selection is very important. I will take.
What is your criteria for selecting them? It's mild ptosis?
Yeah, 2 to 3 millimeter ptosis, 2 millimeter response to phenylephrine.
Okay. Be interesting to know the long-term results.
3 years follow-up I have shown like now.
Shown, okay.
Thank you, ma'am. We'll move on to the next speaker, Dr. Shruti Tara. Our chairman, ARC, Dr. Chitra Ramamurthy, has already introduced her. And Dr. Shruti will be talking on MMG in different scenarios. We just received a message from Dr. Namrata Sharma, our secretary of AIOS. She is trying to log in, but she has some internet issues, so she'll join in later. In the meanwhile, we'll welcome Dr. Shruti Tara, please.
Is it visible, my screen?
Perfect, perfect.
So in the next few minutes, we'll just go through the mucous membrane grafting in different scenarios. It's basically used as a conjunctival replacement. In oculoplasty, we use them as for the socket reconstruction, like in this patient, or a fornix formation in this, the pre and the post-operative pictures you can see. So it's, as I said, it is a replacement for a conjunctiva, and it is for a symblepharon release, where it can be a pseudopterygium, repeat conjunctival surgeries, burns, or even sometimes a cosmetic reasons, like in this patient who has had a limbal dermoid excision done elsewhere and has developed a severe symblepharon of this kind, and it was released and a mucous membrane graft was placed, and later on a tattooing was done to give him an aesthetic appeal at the end of the surgery. And also in alkali burns, wherein there is a loss of fornices, both you can see in this patient, the upper and the lower fornices was completely lost, and the fornix formation was done, and now waiting for the corneal surgeries to happen. And in the Steven-Johnson syndrome, where there is a lid margin keratinization, and which can cause a severe abrasion on the cornea, so it can be replaced with the mucous membrane like this, and the patient can have a relatively white eye. And also in severe cicatricial entropion and following a large surface tumor resection. So other uses are as a protective layer over keratoprosthesis, and in GPC excision as a conjunctival replacement for a non-healing shield ulcer. So this is a small video on retrieval of the mucous membrane. So mucous membrane you can usually done on the lower lip. It can also be done on the buccal mucosa, depending on the amount of mucous membrane that you require. And in this video, you can see that there's a small modification done wherein a pocket is created. The only downside to this is you may not get a very thin mucous membrane in this, because it is a rather blind thing, but the advantage is that the bleeding doesn't spill out and a relatively clean field, and later on you can thin it as per your requirement, and it is fairly quick. So this, when you're not very particular of having a very thin mucous membrane, this technique can be used. So after marking, it's all basically blunt dissection under the mucosa. And the MMG is harvested. So this is one such patient where we used as a protective layer over the keratoprosthesis following a hot oil injury, where there was a blepharophy was created by the plastic surgeons. The whole surface was reconstructed with mucous membrane, and this was of course taken with the buccal mucosa. So after the symblepharon was released, the corneal surgeons did a keratoprosthesis, and later the mucous membrane was harvested, and the entire fornix as well as the surface was reconstructed with this. With the buccal mucous membrane, and this is relatively thicker mucous membrane, and So it's folded and tucked onto the fornix. And a symblepharon ring can be later placed, and a small hole can be made at the center where the prosthesis is around. So giving a visual axis, opening up the visual axis. And later on, for some time, tarsorrhaphy is done and later release. So this is how he is at the end of the procedure. And so as a protective layer over the keratoprosthesis, they say the keratoprosthesis lasts long if covered with the mucous membrane. This is another patient with a non-healing shield ulcer with giant papillary conjunctivitis.
1 minute.
It's 7 o'clock.
And so the really large ones are removed using RF cautery. But then that doesn't usually give us a very smooth surface to place the mucous membrane. So it is shaved using the radio frequency diamond tip probe. And here in this technique, you can see you can harvest a very thin mucous membrane graft by directly visualizing. This takes a little time though, but it is well worth the technique, well worth. So, and this can be further thinned and later replaced as a tarsal conjunctiva. The glue is used to secure it. And the end is, it's closed with the AMG. And this is how the patient is at the end of the procedure. So in the interest of time, I'll skip this. So also for the hot metal injury we used. The other documented indication is the conjunctival insufficiency after filtering glaucoma surgery. And the recent variation is the cultured oral mucosal epithelial transplantation, wherein bits of mucous membrane is taken and placed on the AMG and grown over it. So they've used it with good results, and this article really gives the good insight on that. So MMG is a suitable procedure for replacement of conjunctiva. It's easy accessibility, sufficient size, fast, inexpensive, and high stability, and fairly reliable. Thank you.
That was a very wonderful talk, Dr. Shruti. I have one simple question, and then I would want the expert panel to ask. There could be a technical challenge. Supposing you have an undersized graft or something, how would you deal with that?
So usually what we do is we have to measure how much of graft that you really require, and you have to oversize it by 30%. So it has a shrink, and based on the size that you require, you can either harvest it from the lower lip or from the buccal mucosa. So if you want a larger one, I would take from the buccal, and if I want a fairly smaller one, I would take from the lower lip.
Yeah, just a comment and a question, Shruti. What do you do to the donor site after you harvest the graft? Do you cauterize, leave it?
AMG.
Yeah. Okay.
Cover it with AMG.
Yeah, because I think that technique varies from surgeon to surgeon. It also heals very well if you leave it bare. But what I have found of late is there's a huge amount of patient comfort. If you use fibrin glue, the first day the patient doesn't feel anything at all, and the healing is very fast. So I think that varies from, but nowhere do we undermine. If it's a large graft, if you undermine and suture it, you leave a lot of deformity, because that's something I've heard at some other meetings. Yeah.
Anybody on the expert panel, Dr. Usha, anybody has anything to add here? We will go on to the next speaker.
Dr. Milind, please.
Shruti, nice
I
demonstration.
have a question for you. Do you routinely use AMG for the raw area in the buccal mucosa and the labial mucosa?
Yes, ma'am. We do.
That's an, and does it stay? Because once this patient starts chewing, you use glue, is it?
I use glue, but I also reinforce with 4 sutures on the 4 corners. And usually I give a Zyte gel after, before they have their food. So, it's relatively pain-free for the patients.
Dr. Milind, sir.
So I just wanted to check with Shruti if she debulks the mucous membrane on the back surface always, because some people believe that there are accessory salivary glands. So do you choose to take them or delete them?
It depends. If I want it very, very thin, then I would debulk. But then if I wouldn't mind that it being thick, like how we placed it over the keratoprosthesis, where I really am not too particular that it being too thick, then I would leave it like that.
Thank you.
shall now go on to our next speaker, Dr. Rashmi Gupta, who is consultant oculoplasty from Narayan Netralaya, Bangalore. And she's going to talk on injection Botox for facial spasms. Dr. Rashmi, can you share screen? Yeah.
Okay.
Can you make it full screen, ma'am?
Okay, we are here.
Perfect.
Good morning. Sorry, good evening, all. The periocular dystonias, hemifacial spasm, and essential blepharospasm are not merely cosmetic conditions. So they are both functionally and socially incapacitating for the patients. A very effective treatment is chemodenervation with botulinum toxin. So in this condition, it's very important to make sure that we are talking really about blepharospasm and not reflex blepharospasm. And we need to rule it out by, reducing light or using topical anesthetics to make sure it's not the secondary blepharospasm. It is known that botulinum toxin is a very, very effective treatment for the same. And a lot of people make the mistake of confusing the two. It's very simple. The hemifacial spasm is half a face, it's vertical. Blepharospasm is horizontal, it involves both the eyes. So we'll go on to show it actually on a hemifacial spasm because it's going to show both the upper face and the lower face. And a good dose to start with is 20 units per side in a blepharospasm or 20 units on the single side on hemifacial spasm. So among the pharmacology, what's important to know and to tell the patient is that the action doesn't start immediately. It will take 24 to 72 hours to start an effect and at least 10 to 14 days to have complete effect. And particularly in the older versions, on prolonged usage, there would be a decrease in the sensitivity to the botulinum toxin. We usually dilute it with normal saline. Using water for injection is going to be very irritant and painful for the patient. And often we use either 4 ml or 2 ml per 100 units. And we can calculate the dose we are giving for 0.1 ml in this way. And although the advisory is often that it can be used only within 4 hours, it's actually, we can keep it at room temperature for 4 hours, but if we put it in the refrigerator, it maintains its potency up to 6 weeks. In the pre-injection counseling of the patient, we need to tell them about the side effects, the possible ptosis, dry eye, lag of thalamus, diplopia, and so on. And we have to tell them about the need for retreatment. And very often, you might want to draw a diagram like this, mark out where you've given the injections and what dose, and reassess after a few weeks to finalize the optimum dose and pattern for that particular patient. We need to find out if there's any coagulative disorder or there's any use of anticoagulants. If you end up with a hematoma, you're not going to do a good job. And the injection site skin has to be healthy. We need to clean any makeup and apply topical anesthesia. We can also use an ice pack, which has two effects. One, it reduces the vascularity, so it reduces the chance of a hematoma formation, and it also induces a certain amount of anesthesia. So while injecting, it's very important to know the underlying muscle and the anatomy we are talking about. These are your playgrounds, and including the facial ones, the zygomaticus, depressor anguli oris. And you'll see, particularly in the hemifacial spasm, the pattern differs depending on which muscle is overacting. So botulinum toxin is prepared. In this case, we are injecting 2 ml of normal saline into 50 units of botulinum toxin type A. And we don't shake the bottle vigorously. A gentle rotation should be enough. We make sure that the patient's skin is cleaned. and then we start injecting. Usually, I like to start with the corrugator superciliaris.
1 minute.
I'm using a 1 ml syringe with a 26 gauge needle. And you see, that's the central part. But here, there was the folds of the corrugator further on, which is also injected. In the upper lid, the injection is just subcutaneous in the pre-tarsal area. In the lower lid, we put an injection in the center and laterally. You can ask the patient to show her teeth to figure out where the zygomaticus is. And
Right.
that is where we inject into the bulk of the muscle. This particular patient had a lot of lower face spasms. So depressor anguli oris as well as mentalis is also injected. The panel, if you will allow me, I'll complete this, please. In the lateral aspect, the injection is given outside the lateral orbital rim. Otherwise, it might induce diplopia. We do tell the patient not to touch or rub the face for 4 hours after the injection. And we also tell the patient the possible side effects. Now that we know what to do, we also need to look at what not to do. And the way to avoid these possible side effects is we avoid injecting the preseptal orbicularis where it could diffuse into the levator or the superior rectus. We avoid the medial end of the lower lid where it can cause ectropion and epiphora. We avoid the nasalis muscle, which is going to cause possible difficulty with breathing. And we avoid injecting more medial to the modulus because that can cause drooling from the mouth. So correctly done, it's a very satisfactory procedure. Thank you very much.
Thank you, Dr. Rashmi. That was a brilliant talk. Really had us listening to you every second of the way. I just wanted to ask Dr. Milind or Dr. Usha who could answer. Would you consider in benign essential blepharospasm, or would you consider doing a front pelvis sling surgery as an alternative, or would you combine it with Botox? Or Dr. Usha?
Ma'am?
So first we start off with Botox, and I think once we are not very comfortable or once we've achieved the results that we intend to get, I don't think we need to advocate any surgery. But in case we are not able to get the adequate results, you may have to opt for a surgical procedure in order to make the patient suitable, at least clear the visual axis. So sometimes we may have to combine it with the sling procedure, which is what we advocate. I think some of our cases have to do that. Dr. Milind?
Dr. Milind?
Yeah, I also would agree that sling would be preserved as the last option. Before you would always start with botulinum toxin, and surgically you could do a myectomy. And myectomy can be combined with a sling, or if the myectomy fails, then you could consider a sling. And recently we've been trying the liposome encapsulated doxorubicin, which is having myotoxicity as a side effect. And this side effect is explored as a possible long-term beneficial effect. And the results are close to 50% permanent cure in these patients. So that's also an option in established cases.
Dr. Chitra, just a comment, if I can.
Yes, yes, yes.
Dr. Chitra? Yeah,
yes,
so I think the subset of patients who need surgery, essentially many of them have what is called as apraxia of lid opening in combination with blepharospasm. So those subset of patients do poorly with botulinum toxin, and then they go on to need myectomy, which is a fairly extensive surgery as far as ophthalmologist goes, and sometimes combined with a silicone rod sling. At times, one of the two or both, depending on how bad the condition is. Because it's potentially blinding disease. think that's what ophthalmologists need to understand. That this is a patient who's got perfect eyes, perfect visual pathway, but is functionally blind. Some of these patients actually are, don't stare out of their homes because they don't know when their eyelid will close and when it will not open. So it's not under their command. So they become reclusive, they lose their jobs, they lose their professions. So they are functionally blind. And this is very, very gratifying to treat, like Dr. Roshmi showed. Both botulinum toxin and surgery are life-changing operations, are life-changing procedures. That's all.
Can I ask a question? When you're doing a frontalis sling suspension in these patients, is there any modification in this sling? Or do you use a routine Fox pendant?
Yeah. So the only modification we need to really remember is that the whole orbicularis muscle is gone. I almost never do a frontalis sling alone. So for me, myectomy is much more important because the basic concept is no muscle, no spasm. So if you remove the muscle meticulously, there's going to be no spasm. But so you just have the skin over the silicon rod. And you really have to do an open sky technique and attach the silicon rod to the tarsal plate with multiple sutures, because otherwise it's going to slip. There's no tissue between the silicon rod and the outer world except the skin, because the orbicularis has been meticulously removed. So in that sense, the chances of slippage, etc., are more. And so that's the only, you need to suture it to the tarsal plate very well, because there is no orbicularis muscle as a layer, and you're basically opened up the septum. So many other things may happen.
Yes, sir. Thank you. We'll move on to our next speaker, who is Dr. Prerna Tahilani. She's a practicing oculoplastic surgeon from Mumbai, and she will be discussing canalicular tear repair and its intricacies. She is a visiting consultant at HCG Apex Cancer Hospital, and she's a part of the Mumbai Eye Plastic Surgeons, ophthalmic plastic surgery and ocular oncology consultant. Dr. Prerna, a very warm welcome to you to this ARC meeting. Please go ahead.
Thank you so much, Dr. Satyajit and Dr. Chitra and the ARC team for having me at this discussion. So I'd like to present or display a video of a repair of canalicular tear in a slightly more straightforward case, with a single intention of making it a more approachable and easy surgery for ophthalmologists. Now, these can present in the pediatric as well as the adult age group. However, sometimes the pediatric lacerations can be sealed by themselves due to the fibrin clot. So whenever you see something like a blood clot medial to the punctum, it's important to assess the eyelid properly and not overlook these pediatric lacerations to prevent any long-term lacrimal sequelae. Now, following is a elderly patient who had a medial canthal avulsion. The upper lid was intact and the lower lid had some skin loss. However, this was a more acute injury, not much time had passed and the edges were quite clean. Now, the first hardship what I've seen my residents or general ophthalmologist face here is isolating the cut ends of the canaliculus. One of the ways to do this is you isolate or localize the punctum and dilate it in a very atraumatic, gentle way. Once this punctum dilatation is done, you can introduce a Bowman's probe. Once the Bowman's probe is introduced, it is important to direct it along the direction of the anatomical eyelid. So this will give you an approximate rough idea of where the medial end is suspected to be. Now, in this case, what you see is a white ring just adjacent to the caruncle. More often than not, sometimes you won't find this ring very easily in more dirtier wounds. This ring is nothing but the cut ring. It's also known as the calamari ring sign. This is seen under high magnification. A probe placed there and you find a hard stop will do nothing but consolidate your finding that this is indeed the distal end of the canaliculus. It may not always be so easy. So the other methods of localizing are fluid or viscoelastic irrigation, either assisted with dye or without dye, or injecting an air bubble through the intact canaliculus. And once you see where it comes out from on the cut eyelid, you know where your medial end is. You can irrigate the passage to be 100% sure of the patency of the lacrimal system. What I have done here is I've used a silicone stent. This is a self-retaining monocanalicular stent, or the Oro Monoca. The second hardship, again with the stent, that I feel people find is it's very pliable. Other options are bicanalicular Crawford Monoca, or the bicanalicular Crawford stent, or the Crawford Monoca, or the Masterca. So to make it a little easy to introduce, I usually cut it in a tapering fashion, leaving behind an adequate length so that it is easily threaded into the punctum. If you have good punctal dilatation, the collar of the stent fits snug without any maneuvering, and the other end of the stent should merely be homed into the medial cut end. There is no need to haul it in very vigorously. The softer stents have a tendency to prolapse out. So if there is increased resistance, you have to be aware this could be a false passage. Once you home the stent in or position it, the ends of the canaliculus have to come together slightly. So this is the ideal wound state where there will be adequate tension and not excess tension. Here, because of a little bit of skin loss, I have placed a pericanalicular stitch with a atovicryl. This is a controversial topic because sometimes closer the stitch can cause canalicular stenosis. So if the ends are very sharply cut, you need not place the pericanalicular stitch. Once the skin falls in place, and if the wound is clean without any necrosis, the orbicularis will merely come together and get opposed. So the wound can actually be closed in a single layer with just skin to skin apposition. Else, if there is tissue loss, you may choose to do a buried suture with a 6-ovicryl in the orbicularis muscle.
1 minute.
Yeah, it's almost done. So the anatomical landmarks are apposed on the skin. Here, since the medial canthus was avulsed, I did place a single stitch on the conjunctival side as well. Again, this can be skipped. So this is how the surgery was completed, and this is a fairly decent result. A successful outcome would be functionally if the patient has no epiphora, and anatomically if your syringing is patent in a long-term result. Thank you.
Very nice and descriptive talk, Dr. Prerna. A small question, Dr. Shruti, you can have your questions ready. Would you even intubate an isolated upper canalicular tear?
Yes, I would intubate an isolated upper canalicular tear, though it is it is rarely seen compared to a lower canalicular tear. But the upper canaliculus also drains tears, and there is some amount of epiphora if the upper canalicular tear is left unintubated.
Dr. Shruti, you have any question to ask?
Even if one canaliculus is stone, it is not. It cannot be just left that okay, one is it is there, and so we need not intubate. As an oculoplasty surgeon, all of us agree that we have to intubate whether it is a single canalicular stone or it is both. Dr. Prerna, have you, in an event that both canaliculus are torn, have you used this stents for both the lids?
Yes, I have done that. I have used the monocanalicular stents for both the lids.
And if the canaliculus is torn far too low, would you still recommend using the mini stent, or would you recommend a bicanalicular stent in these patients? Of course, the retrieval would be a little challenging. We might have to use an endoscope to retrieve it.
Correct.
Or of course.
So I think one of the factors that is mentioned in most of these papers that talk of canalicular lacerations is success rate also depends on the skill set of the surgeon. So if you are confident that if it's almost at the common canaliculus or very close to the lacrimal sac, and if you are confident of placing the stent and placing the buried sutures, I think the monocanalicular stent would still be a better option compared to the bicanalicular stent.
Dr. Millen, something to say?
Yeah,
I agree with Prerna because bicanalicular stent essentially would involve manipulation in the nasal cavity. And Monoka completely avoids that. So you stay on the surface, so less injury to tissues.
Yeah, Shruti, just a comment if I can.
Yes, sir. Sir.
Yeah. A couple of things actually. All these techniques of identifying the cut medial end were all pre-microscope. They were all described in the era before microsurgery. So today, I think it's almost 100% of the time you find the cut medial end, unless it's a real avulsion. So with microsurgery, with microscopic magnification, finding the cut end, as the Dr. Prerna very nicely showed and described. Sometimes instead of being circular, it can be little slit because of the edema, but still it will be paler and one can easily find it out. The second is about pericanalicular suturing. I think 10-0 monofilament also is a good suture to use because we feel more confident if the pericanalicular tissues are somehow put together over the stent and they are before we start the suturing of the lid itself. So I think these two comments possibly, we will always find the medial cut end, fortunately today, and things like pig-toe probe, which are described in the books, are basically far too traumatic to use in most cases. Thank you.
We shall now go on to the next segment of our webinar, that is the virtual oculoplasty clinic, wherein different cases are going to be discussed and would bring forth one relevant pearl. It's very unfortunate that Dr. Vikas, who was to be our first speaker, has not joined it because he was not keeping well, and I just hoped and kept him on because I thought if he's a little better, he could participate. It's our loss not to have him in this session. Dr. Satyajit, could you introduce our next speaker? Dr. Satyajit?
Yes, ma'am.
Could you introduce our next speaker? Dr. Kamalji?
Our next speaker will be Dr. Kamalpreet Likhari. She went through her wonderful 15-year stint as postgraduate fellow, and then she is a consultant at Arvind Eye Hospital, Madurai, and is presently the head of Orbit and Oculoplasty Department. I would like to welcome Dr. Kamalpreet Likhari, please.
Thank you. Good evening, everybody. At the outset, I'd like to thank the organizers for this opportunity.
Dr. Kamalpreet is the head of the RJN Apollo Spectra Eye Institute in Gwalior.
Yeah, I'm in Gwalior. Okay, is my slides visible?
Yes.
Okay, so I'm going to talk about the silicone sling simplified. Now, we all know that the beauty of frontalis sling surgery for ptosis using silicone lies in its simplicity. However, we realize the importance of understanding the intricacies of this procedure when we see its complications, like in this young lady who had congenital synkinetic ptosis and had been operated more than 3 times before she presented to us. So she had this obvious contour abnormality, and you can see in the subbrow area, there is a punched up hypertrophied tissue. So she had undergone a silicone sling followed by a sling tightening, then sling removal, and then a fascial eta sling. This girl also had a congenital synkinetic ptosis, and she had undergone a silicone sling procedure. She had a medial droop and an undercorrection. So now to understand the procedure, we are trying to engage the frontalis muscle to lift up the ptotic eyelid. And the most commonly followed route is the Fox pentagon. The markings are shown. And the most important markings are those on the eyelid, which should correspond to the medial and the lateral canthus with the eye in primary position. We are using the Oro sling, which consists of a thread-like silicone rod swaged onto long needles. Here is a brief video. Now, bending the needle makes its passage easier and also safer. So I have already made the stab incisions in this case. And before starting the procedure, it is nice if we do a blepharoplasty incision and also make a tunnel under the brow incision beneath the frontalis. Now, blepharoplasty really helps in giving good cosmesis and also prevents lash ptosis, also makes the passage of the needle easier. I like to start on the medial side, on the nasal side, because sometimes when you are coming from the lid to the brow on the nasal side, the frontal prominence can present an obstruction. Now here the plane of the needle is in the plane of the levator. We should make sure that we are not engaging the arcus marginalis or the orbital septum. Also, when we are passing the needle in the eyelid, we should make sure that the tarsus is not engaged. In fact, we always evert the eyelid to make sure that the tarsus has not been penetrated before we complete the pass of the needle. Another point is that when we do a blepharoplasty in a unilateral skin sling case, it is always a skin muscle excision. We never excise fat because we want to preserve the symmetry. Now this needle emerges about 4 to 5 millimeters away from the other silicone thread and has to be very carefully threaded through the sleeve, taking care not to damage the sleeve because otherwise we have to discard the sling. The blepharoplasty is closed with the crease forming sutures and skin closing sutures. The sling is tensed and the patient is made to sit up to assess the result. A lot of people like to tie a suture around the sleeve to secure it. I prefer these knots, I find them simpler. So I just tie knots on both the rods of the sling, cut it to a suitable length and bury it in the pocket which we had dissected earlier. Now, a very important pointer here is that no part of the sling should lie outside this pocket because that can lead to infection and granuloma formation. Therefore, it's better to close this in layers. Following these steps can ensure very predictable and symmetrical results, not just in simple cases like this, but also in complex ones. So for this young lady, I removed the fascia lata sling and I debulked the subbrow tissue and passed a silicone sling. This is at 2 weeks post-operative. In this girl, we found that she had a marked esotropia in the right eye, which had been missed earlier. So we made her aware of that and kind of counseled her to accept a bit of a contour abnormality and then proceeded to correct it. Now coming to pearls, the most important is crease and contour. If you have a symmetrical crease and contour, you can get away with a bit of asymmetry in lid height, that is overcorrection or undercorrection. Always do a cover-uncover and an alternate cover test to rule out squint and look for frontalis overaction, which is most important in unilateral cases than in bilateral ones.
1 minute.
Having a printout in OT really helps you to assess the other eye lid height and contour, which may not be very possible otherwise. Assess the patient in a sitting position before closing the case, unless of course you're operating under GA, and counsel thoroughly. So photographs holding up the ptotic eyelids can help the patient to understand your planned final result along with lag of thalamus and lid lag and down gaze. This not only helps the patient have realistic expectations from the surgery, but also gives mental peace both to the patient and the surgeon. Thank you.
Wonderful, Doctor. It was a very nice presentation, Kamalpreet. I suppose these patients you all would have counseled a lot so that, you know, their expectations would be quite escalated. So if you've had overcorrection or undercorrection, would you leave it for time to take care, or there are certain clear-cut indications when you should intervene?
Ma'am, definitely for an undercorrection, unless it's really gross, I would wait for the 2-week period to wear off when the edema clears slightly. If it is a gross overcorrection, you can even do it after 5 days because that looks very unacceptable.
Anybody, Dr. Usha, you have anything to add?
Chitra ma'am, your video is off.
Yeah, so that was a very good presentation, Kamalpreet, and I think anybody would accept an undercorrection, but an overcorrection would be a big no-no.
Yeah.
So, yeah.
Just a small comment, Dr. Kamalpreet, very nice video and presentation. The fact that you emphasized, showing how the patient is going to look when he looks down or sleeps. That is lid lag and lag of thalamus. If you demonstrate to especially the child's parents, then that's a very, very nice point that you added.
Thank you, sir.
Thank you very much, Doctor. So we shall now go on to our next speaker, Dr. Senthil Nathan, a very well-known oculoplasty expert with this very interesting one case, one pearl for all of us. Dr. Sendil Nadal is the chairman and medical director of Ramana Eye Center, Chennai. He's also a visiting consultant at Rajan Eye Care and Bill Roth Hospital. On to you, Dr. Sendil Nadal.
Thank you, madam. Very good evening to all of you. At the outset, I'd like to thank the AIOS-ARC, Chitra madam and Dr. Satyajit for giving me an opportunity. Can you see my screen, please?
Yes, sir.
Yeah. So today I'm going to discuss an interesting case which we had a few months ago. And this was the patient who came to us. We had operated DCR with a silastic intubation done a few months back. And since I'd done it in a different hospital, the patient actually came with a small tube prolapse 2 or 3 months after the surgery. And the fellow there was handling the patient. And what he did was, since the tube was visible from the ocular end, he tried to just pull the tube and see if he could take it out from the eye end itself. And this is what happened. Actually, he pulled the whole tube out up to the knot, but he was not able to remove the tube because it was knotted at the end. And then he was stuck with the problem because the tube was completely out, but he was not able to take it. And then he had to call me and I had to go and manage the case. And when I saw the patient, it was like this. And you can see that's a very huge tube prolapse. And how do we go about this? Now you can see that this patient has got a very big tube prolapse rubbing on the cornea. So how do you do this? And when we did a rhinoscopic examination, just put a speculum on the nose, we are not able to see the knot end at all. So we are just planning how to do it. And the right way actually to approach this problem is, if you can't see the knot, you have to use an endoscope. Do a nasal endoscopy. And first, try to see the nasal end of the knot. That's the most important thing. Don't try to pull the tube from the eye end because there's a big knot there and you'll not be able to take it. This is the first pass. You can see that's the middle turbinate there. This is the middle turbinate, and that's the ostium. And this is the tube. You can see the knotted end of the tube there. So this is the knot of the tube. So this you have to first identify. And once you've identified that, you're under endoscopic guidance, you have to hold the knot first, which is almost right at the ostium of the DCR. You have to hold the knot and you have to gently pull it so that you can see it with a simple nasal speculum itself. So that's what you need to do. First, catch the knot and try to pull it. And once you do it, automatically the whole tube on the ocular end will come into place. And once you have done that, now you go ahead and cut the ocular end using a scissor. And then now you will be able to pull the silastic tube from the nasal end very easily. And this is how we have to go about tackling this problem. So you can see the whole tube has been removed. And this is what you need to do. This is a very small pearl. So whenever you have whenever you're planning a routine silastic tube removal also, always do an anterior rhinoscopic examination with a simple nasal speculum. See if you can see the nasal end, see if you can see the knot. If you can see the knot, then it's fine. But if you can't see the knot, if the knot is retracted way into the nasal cavity, don't attempt to cut the tube at the ocular end because you will not be able to pull the tube out. And there's a risk the patient might aspirate the tube. It might go into the lung of the patient. So if you can't see the knot, use an endoscope and hold the nasal end first and then cut the ocular end. In that way, it's a much more controlled and safer procedure, and you can avoid a lost tube or aspiration for the patient. Thank you very much.
Thank you very much, doctor. That was a great pearl. But if you do not have an endoscope, what would you do?
Yeah, if you don't have an endoscope and if you can't visualize the nasal end, what you can do is you can actually ask the patient to blow his nose firmly. You ask him to occlude the normal side, and you have to ask him to blow the nose. And by come into visualization. And even after forceful blowing, if you can't see the tube, then you need to post it on another day, get help of a local ENT surgeon who can just bring the endoscope to your center, or you can go there and do it as a combined procedure. It's a very simple procedure, hardly takes few minutes. But if you can't see the knot, it will not be possible for you to retrieve the tube. So you first ask him to blow or even sneeze. And if you can't see the knot, then better to fix it on because it's a planned procedure. You can always fix it on another day, coordinate with your ENT surgeon and do it.
Thank you, Dr. Shruti. Any question?
Thanks, Dr. Yes. for the ophthalmologists who don't have an endoscope, it is a problem. So generally what a small pearl that I learned from my mentor was, like, as much as possible, if you don't have an endoscope, if you have an endoscope, good. If you're using it, great. But we just put a single square knot, just one small square knot, and we retrieve it from the common canaliculus itself. So the pearl here is only if you have put the knot, you remove it. Somebody else has put the knot, don't venture, because you don't know how many knots they've put in there.
Dr. Sati, one small question to Senthil.
Yes, sir.
Hello. Yeah.
Yeah,
Dr.
yes, sir.
Senthil, how many days following surgery was this tube coming out?
Yeah, this is actually around 2 months, sir.
2 months. So I think it was good time to take out anyway.
Good
But
time to
let's
take it
say-
out anyway, yeah.
Anyway, so if it had happened, let's say 4 days after surgery or 5 days or in the first week, would you have tried to pull it down, retain it in some way within the nasal cavity rather than taking it out?
Yeah, one option is you can just pull the knot, use the endoscope and just pull the knot and keep it in position and just leave it like that. Just counsel the patient not to put his finger on the medial canthus and try to pull it. This happened because the doctor actually pulled it using a forceps. Otherwise, it was not the problem of the patient. He had a very small tube prolapse. So such huge prolapse usually happens when they inadvertently put their finger there and rub. They get the whole tube out. So what you can do instead of trying to suture the tube into place in the nasal cavity, which is slightly traumatic because the nasal cavity is already very vascular. If you counsel the patient, tell them very carefully that you have a tube there, you put your finger, it will come out, and then we'll have to do a procedure to put it back into place. Counsel them, and on the 1 month time, I don't think it should be a big issue. Yeah. Pediatric always suture it. When you're doing the surgery, then you have a simple stitch and anchor the tube into the lateral wall of the.
Yeah, because sometimes the tube has a memory, and if it's been out for a long time, then even if you pull down, the same set of factors which caused it in the first place may come in. So some kind of securing, if you can do that better, especially if you want to retain it for some time.
Yeah.
Thank you.
I have a point. So I think we have to make this aware to the other ophthalmologists as well, because a lot of times there's a tendency when there is a slippage, they tend to remove it or rip it. You know,
Very true.
Dr. Senthil, you should be very glad that it was not ripped away and you were called even before.
Yeah.
So
Because actually, why I made this pearl was, man, because even some consultants whom I know, they say they cut it from the eye end and say the patient just follows it, nothing happens. But it can go into either cavity, it can go into your trachea also. And I've had patients where it's gone into trachea and we need to use a bronchoscope to take it out. So it's not, you can't take it very lightly, just cut it and say, it'll just, he swallows it and it comes out next day with this thing. That's not actually, it's not so simple. You can have a bad aspiration. So you have to take it out yourself physically, make sure it's completely out.
Thank you very much. Dr. Satyajit, would you introduce the next speaker?
Thank you, ma'am. Our next speaker is Dr. Namrata Adulkar, another very promising ophthalmologist from Mumbai. She'll be making, she's a consultant ophthalmologist, oculoplastic orbital surgeon and facial aesthetics from Sir H.N. Reliance Foundation Hospital, Mumbai. And she is also a consultant at Dr. L.H. Hiranandani Hospital, Mumbai. A very warm welcome to this ARC session, Dr. Namrata Adulkar, please.
Good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity. Am I audible here?
Yes, please go ahead.
So today I'm going to share one of my cases that I recently happened to manage. This was a patient of invasive sino-orbital mucormycosis in a patient who had recently recovered from SARS-CoV-19 infection. I have no financial disclosures here. This was a 47-year-old healthy gentleman previously who presented with left-sided proptosis pain and sudden loss of vision of 2 days duration. He gave history of SARS-CoV-19 pneumonia, for which he was hospitalized and discharged just 2 days prior to onset of ocular complaints. Details of his previous treatment of COVID included he had a rather stormy course and was hospitalized for nearly more than 2 weeks. Received remdesivir, meropenem, IVMT for 5 days, followed by oral dexamethasone. He was also on anticoagulants. He had an interleukin storm and was treated with tocilizumab for 3 days. He also received non-invasive ventilation for 4 days and treated with a lot of steroids. He was discharged. Luckily, he did well, and he was discharged on day 16. And 2 days later, boom, this is how he presented to us. Left eye vision, no PS. He had a fixed dilated pupil with complete ophthalmoplegia, severe proptosis, severe chemosis, and fundus examination revealed a central retinal artery occlusion. There was also blackish crusting at the knees, at the external nares, which is not seen in this picture. So we were suspecting mucor, and this was the MRI of the patient. So you can see altered intensity of signal in the left orbit, thickened and dilated superior ophthalmic vein. The optic nerve on the left side was also thickened with dilatation of the arachnoid space. And the carotid sinus showed a filling defect on the contrast scan with the lateral convexity suggestive of a cavernous sinus thrombosis on the left side. Patient's labs came out negative for RT-PCR for COVID, considering he had recently recovered from COVID and discharged only when the PCR was negative. He had, as expected, elevated IgG titers, a titer of 7.08, which is considered to be quite high. So normal titers, the titer which is less than 1.4 is considered as negative, and anything more than 1.4 is considered as positive, and more than 5 is high positive. His hemoglobin was normal. The WBC counts were within normal range with a normal lymphocyte percentage. His sugars were deranged with an HbA1c of 13. Mind you, he was previously absolutely healthy, hale and hearty, nothing at all before COVID hit him. His creat was 0.8 and inflammatory markers were elevated, CRP, ESR both. The nasal swab was done and KOH mount tested positive for mucor. So patient was started on injection amphotericin B, the conventional one, along with vancomycin, and he continued on his anticoagulants. Insulin along with OHAs were used to control his sugars. Along with that, he received supportive treatment in the form of pain meds, liver supplements, antacids, and so on and so forth. He was planned for surgical debridement of the sinuses and the orbit. We went ahead and did a left orbital exenteration along with pan-sinus debridement with a partial maxillectomy. I'm sorry, I don't have the endoscopic pictures, but this is what I found after exenterating the socket. So you see extensive rarification and necrosis of the bone. The lamina papracia, which was missing on the scans, was also seen missing in the patient with dead necrotic bone at places. So this was the infraorbital nerve, which was thickened almost 3 times the normal size and looked dirty gray, which is unhealthy, along with areas of extremely thinned out bone. So this confirmed that it was a very aggressive kind of disease, and the idea to exenterate was bang on.
1 minute.
Histopathology confirmed mucor, the typical findings of occlusive vasculitis with extensive granulation. Pass staining showed aseptate broad hyphae, again confirming mucor. Patient recovered quite well. He did undergo regular sinus cleaning every 2-3 days, along with his glycemic control, which also improved. And he was discharged after 3 weeks of treatment with amphotericin and was continued on oral posaconazole. So this was a patient 3 weeks later after on discharge, and he was quite happy and well. So coming to COVID-19, as we all know, it causes a range of disease patterns ranging from mild to life-threatening pneumonia. And now we also know that it is associated with wide range of bacterial and fungal co-infections. Now, why does it have so much why is it considered high risk for fungal co-infections? One, because COVID has propensity to cause extensive pulmonary disease and subsequent alveolar interstitial pathology, which causes a generalized state of hypoxia at tissue level, which, as we know, is a breeding ground for fungal infections. It causes immune dysregulation, in which it causes reduction in the numbers of CD4 plus and CD8 plus T lymphocytes, which may alter the innate immunity, which is again the forerunner of immunity against fungal infections. So these are 2 reasons why, hypothesized reasons why fungal co-infections are common in patients with COVID. I found in literature 2 similar case reports of patients who presented with COVID and rhino-orbital mucormycosis. However, both the patients, one patient reported by Mehta and all, was a 60-year-old gentleman with long-standing diabetes who succumbed on day 6 of medical management. Another patient, a young patient who presented with left-sided mucormycosis and altered sensorium, was found to be in diabetic ketoacidosis along with COVID-19 infection. And again, patient succumbed on a week after the infection. So to conclude, COVID-19 is associated with significant incidence of secondary infections, both bacterial and fungal, probably due to immune dysregulation, widespread use of steroids, monoclonal antibodies, broad spectrum antibiotics may lead to development or exacerbation of pre-existing fungal diseases. So my one pearl here would be an early diagnosis. It's important to be fungal minded, as they call it. My ENT colleagues keep telling me that in these patients, we need to be fungal minded. We need to think fungal. So diagnose it early and aggressively manage them with debridement surgically to debulk the disease, so as the amphotericin B is reaching the tissues that it actually needs to. Thank you.
Thank you. That was an amazing presentation, Doctor. I think a lot of learning for me, because it's a disease which is still evolving. Would there be any time when you will not be as aggressive to exenterate, when you would hold back? That's one question. And the second question is, what are the extra precautions you took in this COVID patient?
So all the precautions, so COVID-wise, he was a safe patient because he had high levels of anti-IgG COVID titers. So he was a safe patient COVID-wise. Even after that, we did follow all precautions that all patients who are undergoing GA in COVID times are to be followed. Secondly, if the patient presents with an advanced disease, aggressive, rapidly progressing condition, like on presentation, he was no PL, with a disease which was already in the cavernous sinus, apex, which is already showing low attenuation and a fixed dilated pupil with the CRAO, I think these are indications that it is safe to exenterate these patients to prevent the further spread of the infection to the CNS. Because mortality in these patients, if not intervened early, is really high. And if you intervene and exenterate these patients early, we can reduce the mortality by almost 30%.
Namrata, can you just quickly tell me where the involvement in your stand was, because my internet connection is unstable. See, a lot of these swab tests, a lot of discussion about this is going on in our oculoplasty group. Usha and everyone will agree whether to exenterate or not, because we are definitely seeing a surge of these cases. I think the swab being taken by science graduates and these technicians who are not even trained is a very big risk factor. We have had doctors who have had fungus sitting in the ethmoid sinus. I think they perforate near the cribriform plates. They go really posterior, they have to get. So that's a very important point when you're doing the RT-PCR. I don't know whether this photo is clear, but just go on to that RT-PCR test and see the images there. How posterior one has to go. I think this is a food for thought, because suddenly when we see a surge of fungus, but I think that this has a cause also. It's not just the steroids and that alone which is causing the problem, but I think the swab test there you have to be really very careful.
Right, ma'am. Point taken.
Wonderful, Namrata. I think it's a first case which has survived as of now. So I think it's time for you to report it immediately.
Because I'm now facing two, what to do. One luckily we're thought to have a nasopharyngeal carcinoma, and with all those lung seedings, COVID, the lungs showed all the COVID features. Luckily, it turned out to be fungus only. The other doctor, I think, needs exenteration, and I'm not willing to exenterate. I'm really not willing to exenterate.
Thank you very much. Following on her, we have now Dr. Aditi Pujari, who's from Sunaina Oculoplastic Surgeons, Solapur, who's going to give her valued inputs to what we are already learning.
Good evening all. First of all, I would like to thank the AIOS-ARC team and Dr. Chitra madam to give me the opportunity to interact with you all. So my case is a 65 years old female who came with complaints of left eye irritation since several months. She had history of multiple sittings of epilation from the left upper eyelid, which was followed by 2 sittings of laser lash removal, which was done by some dermatologist for permanent lash removal. And then the patient was referred to me for upper lid entropion correction. So on examination, the patient showed a few signs of upper eyelid entropion with absence of lashes, which I thought was a sequelae of the repeated epilation and the laser procedure. On upgaze, it shows the similar thing, but on lid eversion, it was something different. So on lid eversion, there was rounding of lid margins with effacement of the meigomian gland orifices. There was definitely absence of lashes with telangiectasia. But these two findings, we were not sure if they are effect of some primary lid pathology or as a sequelae of the previous procedures which was done. So the clinical impression, obviously, with the clinical features was left upper lid lesion to rule out sebaceous gland carcinoma because of the atypical things which were atypical in entropion but typical of SGC. Obviously, we had kept a rare possibility of sequelae of laser lash removal because personally I had not seen eyelid how it looks post laser lash removal. So plan of treatment was incision biopsy of the upper eyelid lesion to prove or rule out the carcinoma and further treatment as per histopathology. So histopathology of the incision biopsy as expected was poorly differentiated sebaceous gland carcinoma. So the patient was taken for a definitive surgery of complete excision of the lesion with 4 mm clinically clear margins, which was confirmed on frozen section, and in the same sitting the patient was taken for lid reconstruction which was done by Cutler Beard lid sharing flap. So this was the patient pre-op. This was after the stage 1 of the Cutler Beard procedure, and this was post Cutler Beard procedure stage 2. So coming to the sebaceous gland carcinoma, as we know, it is the most common eyelid malignancy in Asian Indian population. It is considered among the most lethal of all ocular adnexal tumors. That is, as it is very aggressive local behavior and metastasis. It can also metastasize to regional lymph nodes. So when do we actually suspect SGC? It's actually rounding of lid margins, loss of lashes as seen in these cases, telangiectasia, and histopathologically it was proved. Similar case was referred, you can actually see the suture which was done by some referring ophthalmologist. So these are the cases which we should not miss, because if we treat them in time, we can actually do it with a simpler reconstruction techniques and less invasive or less complex surgeries. These kind of cases where we actually see the lid mass, the important thing is to evert the eyelid, because eversion will give idea towards the actual size of the lesion, which is more obvious on lid eversion.
1 minute.
Common masquerade is recurrent chalazion at the same site even after the incision and curettage. On lid eversion, it can actually give some clue about the actual pathology. So sometimes on lid eversion, you can actually see the previous incision and curettage marking also. So these kind of large chalazia, which actually go beyond the tarsal margin, we should suspect a malignancy rather than a simple chalazion. These kind of lesions where, you can actually see the increased vascularity will give a clue towards the etiology, and eversion will make the clinical impression more obvious. Sorry. Just a minute. I just need. Yeah, sorry. Yeah. Cannot move my slides. Yeah. Unilateral blepharitis, which is not responding to the treatment, we should suspect sebaceous gland carcinoma. Incision biopsy will give a definitive diagnosis about it. Unilateral blepharoconjunctivitis not responding to the treatment should undergo a MAP biopsy, where we take actual 17 small bits of biopsy because the management is going to change if it is confirmed that the whole of the conjunctival surface is involved.
Time.
So yeah. So how can we actually help to avoid the delay in diagnosis in these cases? We should have high index of clinical suspicion. We should always send chalazion for histopathological examination if we actually tend to see some solid material instead of a simple paste-like thing which we commonly see in the chalazion incision curettage. We should have low threshold for biopsy. Map biopsy, we should not hesitate to do whenever it is needed. It is important to communicate with the pathologist, and we should send few specifications while sending the specimen. And I would re-emphasize the thing on eversion of the eyelid while doing a clinical examination. So thorough clinical examination with good reconstruction plan will definitely give you a very good cosmetic as well as functional outcome in these cases. Thank you.
Thank you very much, Doctor. I have one question before Dr. Shruti can take over. After resection, what is the role of frozen section?
Frozen section basically will give a clue about if we have completely removed the tumor. So because if some pagetoid spread is there, we need to be sure about complete excision of the tumor mass, as well as we can safely do the reconstruction procedure in the same sitting. We need not wait for the permanent sections, because more than 90% of the times the frozen section will actually correspond to the permanent histopathological sections and report margin clearance.
Thank you very much. Dr. Shruti, you have anything to add? Dr. Shruti?
It was a very interesting talk, Dr. Aditi, and the points taken, you have to avert the lid and see, and to see if there's anything abnormal, and then take it from there. Dr. Lakshmi, do you have any comments to make on this? Dr. Lakshmi, madam?
No, nothing. Thank you.
Dr. Shruti, just a couple of points if I can.
Yeah.
Very, very nice presentation. I think all the points have been very beautifully highlighted. Just need to emphasize that in a patient with chronic unilateral red eye and a pagetoid form of the tumor, you may not have the typical lid mass, and it may just be a velvety swelling overall even, in which case you don't need a map biopsy. Actually, you need to biopsy any abnormal part of the conjunctiva which is thickened, and that itself will give the diagnosis. So chronic unilateral red eye, blepharitis, blepharoconjunctivitis, which does not improve with time, and the patient changes doctors and drops. Sometimes we see the patient after 3 years or 4 years of the disease. So that's again something which we need to keep in mind and take care, because that's a life-saving thing to treat the patient early. Thank you.
Thank you. Dr. Satyajit, could you introduce the last speaker in this section?
Yes, ma'am. Thank you, ma'am.
Can you stop sharing the screen?
This is her presentation.
Oh, Preeti's presentation, yeah.
I'd like to take this privilege of introducing Dr. Preeti Uday. She is another leading oculoplasty surgeon from Chennai. She is the medical director and consultant oculoplasty surgeon of DRR Eye Care and Oculoplasty Hospital, Chennai. And she's a visiting consultant to numerous hospitals, and we will be happy to hear her words of wisdom. Dr. Preeti, a very warm welcome to this ARC session.
Thank you so much, Dr. Sinha, and good evening to all of you. At the outset, I'd like to thank Dr. Chitra and the ARC team for this wonderful webinar and the opportunity. I'll be speaking on optimal rehabilitation post-severe orbital trauma. So whenever we have trauma, severe orbital trauma like this, where the orbit is shattered, many a times the patient loses that eye because of open globe injury and phthisis. Now, in these cases, usually rehabilitation is done by socket reconstruction, which is very much inadequate. Now, these are the patients who are severely devastated by the whole episode, and they have a long life to lead, and they need an appropriate cosmetic rehabilitation. Most of the time, what I see is the surgeon is comfortable doing the floor repair. They are comfortable with the zygoma, but what is left behind is the naso-orbito-ethmoid complex, because this is a complex surgery, and most of the time this area is left behind, which leads to this kind of a deformity. You can see that if you just use the processes in these patients, they will have the processes displaced outwards and downwards with poor cosmesis. Now, a similar patient like this who had 4 surgeries done elsewhere, you can see the socket is done well. The conformer is getting retained, but again, the socket is down and out, and he will not have an appropriate cosmesis because this NOE area, that is the naso-orbito-ethmoid area, and the telecanthus is not handled. Now, coming to the NOE fractures, The problem fractures are the type 3 fractures where you have comminuted fractures and you have avulsion of the medial canthal tendon. In these cases, in acute setting, we are able to reconstruct the entire complex well with plates as well as transnasal wiring. But when you have secondary rehabilitation or secondary reconstruction, which is the common situation in which the patient comes to an oculoplastic consultant, what we are left with is only bone grafts like this, wherever the bone is deficit, like this bone graft on the dorsum nasum, dorsum of the nasal cavity. Or if there is an excess bone like this, where there is bony callus or malunited fracture, you need to remove this bony callus and then cause the reconstruction. So we present this, I'm going to present this patient who is a 26-year-old gentleman who had a loss of eye because of open globe injury. He has a total ptosis as well as a telecanthus. Now the CT scan showed a severe NOE fracture involving the frontal bone also, as well as the floor of the orbit. Now, in these cases, it is important to take an ENT consult before doing the surgery because they can have chronic sinusitis, which can infect your implants. And also in some cases where there is a cribriform fracture, you need to take a neurosurgeon opinion before you go ahead with the surgery. Now, this is a 3D printed skull model of this patient. We planned the surgery. We have removed this excess of bone and we have pre-contoured a mesh onto this area, which will help us correct the telecanthus. And we will use a second implant for the floor as well as the medial wall. Now here I have used navigation to help us symmetrize the bony orbits. So what we do is the normal orbit is mirrored onto the abnormal orbit. And this mirrored image we then use as a template for reconstruction with real-time guidance during surgery. So here the patient has already had the telecanthus mesh in place. This is the second mesh that I am putting for the floor and the medial wall. Once the mesh is in appropriate position,
other specialty consultants in order to achieve the best outcomes.
Thank you, Dr. Usha. We shall go to the grand finale that is going to be led by 3 stalwarts who are going to showcase the most difficult cases. The first to lead is Dr. Shubhra Goel. Dr. Shubhra is a consultant ophthalmic plastic surgeon from Apollo Hospitals, Hyderabad. And she's also the director and co-founder of the Foresight Worldwide Limited and Bricks Impact Partners. Let's hear from you, Dr. Shubhra.
Thank you so much, ma'am. A very good evening and a warm evening to each and everyone, to my fellow colleagues, friends, and my seniors. And thank you so much for having me on this wonderful webinar. Been a great learning experience. So I was asked to present the most difficult case, which was kind of difficult to decide which was the most difficult case, but I'm going to present something which I thought was difficult in understanding and in my hands and took a lot of time. Not so much in terms of dealing with it scientifically, but because of the other issues involved in that. So I'll be just, going through that. Okay. Yeah. So the first case is about a girl who is around 35 years old. I'm sorry for this picture because she's not asked me to reveal full face, so I have to crop it and show it in a very unmanly manner. But she had dermal fillers which were injected on her at least 3 times in a year. Now, the first time she got injected was on her chin, and she kind of tolerated those injections pretty well. And the second time it was done when I was training certain students, and she was one of the subjects, and she kind of volunteered that she could be injected upon for her tear trough and mid-cheek area. And everything went well on table and during the session, as they may say. And we were all happy that we have achieved great results. But to my surprise, after at least 6 to 8 months, this girl turns up and calls me up and reminds me that she was the one who was treated during the training session. And now she's having this issue where she has a lot of pain and edema on the left side of her face. And she has been, going from one place to another. So what was happening to her is that she was having waxing and waning symptoms on her left side, where there was swelling followed by pain. And she also had as if some ants or, insects were crawling under her skin. Now, to my surprise, what had happened is because she was going from place to place, she was given all kinds of treatments, including she had gone to a gynecologist because somebody told her that it could be related to some gynec issues, which was very surprising. 2 trigeminal neuralgia, which she was treated on, and she went literally in depression. Obviously, when she presented, she had a painful swelling on the left side. It was almost like a cellulitis on the left side, and the right side also there was periocular fullness and pain. So obviously we went ahead, and the first thing which we did is to dissolve the whole product with hyaluronidase. And it took me at least 3 months to dissolve the whole products, put her on medications, which was the steroid coverage and antibiotics to take care of the edema, the swelling, the waxing waning symptoms, and the pain which was involved with it. So I will just hold on the case here because I'll come to the discussion at at a later stage. Now, this is why this is being chosen as one of the difficult cases, because this is what you see me here. This is my face, which is unrecognizable. So I went ahead with the skin hydration fillers on my face, and this is what I landed up after 3 months of my fillers. Initially, I couldn't understand this. I thought I'm hypothyroid and I'm having periocular fullness, and this is what I landed up. Though I was not having any pain, it was just a painless full face anasarca kind of a thing, generalized edema on my face. And obviously I realized that it is related to dermal fillers, and I took some steroids, and I didn't dissolve the products. I just they took some steroids and they resolved on their own. So these are one of the two, out of the whole list, there are 2 cases which I wanted to present. So I want to bring the focus to, edema, which happens post dermal fillers, which is often overlooked, because what is happening in the filler industry is that people are not understanding that this is a medical device which is being given. It's equal to the medical device, and it's injected on the face, and there are a lot of things which can happen as a delayed reaction. So something like post-interventional edema, malar edema, we all understand. Even the immediate, kind of hypersensitivity reaction, the type 1 reactions, we understand, and they're easy to handle. But the problem comes when we have the delayed type of hypersensitivity reaction, which is type 4, which can happen anywhere between days to months to years. I have even seen one patient who presented after 2 years of injections of hyaluronic acid fillers, and the same story was, was existing. So why does this happen is because now the incidence of these kind of reactions is around 0.02 to 4%, which has been documented in literature. Definitely it depends upon the type of filler, the way the filler was injected, and at what depth was it injected. And what has been noted is that the Y-cross technology is causing it more than the hyalocross technology. But the reports are varied. So we cannot really pinpoint at one product or one kind of cross-linking which is causing this, but delayed hypersensitivity reactions are pretty common. And the interesting part is that it is not necessary for the same individual to get the reaction every time, because obviously we understand this is T cell mediated reactions which are happening. So the problem now is how do we deal it, because it becomes quite painful, quite depressing for the patient. Now, when it happened to me, obviously I was also shocked to see what had happened to my face, but I could handle it. But for the patient, it is not easy. And believe me, it is a long haul where you have to treat the patients and they stay with you for months together. So the consensus has been, apart from taking all the proper precautions, which is being mentioned in the 20-point plan for avoiding the hyaluronic acid filler complications by Zolda et al., which is a beautiful paper, and I would recommend everyone to have a look at it. The most important thing is that you need to be with the patient in this journey. And every case of delayed hypersensitivity, unless until proven otherwise, is a case of biofilm or granuloma or inflammatory nodules. So we cannot really differentiate between inflammatory, the biofilm or a delayed hypersensitivity reaction alone until unless proved otherwise. So we have to treat it that way. So whether, the protocol which goes ahead is that as soon as we receive the patient, the first most thing is to dissolve the product, have multiple settings. So you have to dissolve with hyaluronidase under the steroid cover. And this has to be done multiple times, because what happens is once the filler is inside, it kind of forms a coating around it, a fibrous coating, and it keeps traveling along the septae. So if you dissolve it one area, it would, come to the other area because it had always transferred through the septae. That's why the waxing and waning happens. And then we have to enter the antibiotics in forms of ciprofloxacin, clarithromycin. I usually give clarithromycin, which has to be given for up to even 6 weeks, if not 3 weeks. And then you have to have a close follow-up with these patients. So in short, I just want to comment upon that dermal fillers are, yes, they're fascinating and to be given on faces for facial rejuvenations, but we need to be ready with so this is one of the complications amongst the many other, which are, we usually talk about the vascular complications of fillers, but not about the delayed hypersensitivity as much. And once a patient has had an hypersensitivity, is always going to have a hypersensitivity sooner or later. So even if that client is coming back for repeat injections, it has to be consented and told that this can happen, and it is better to have them under the steroid and antibiotic cover, even if you're going ahead and taking them, giving them a repeat injection. So I would rest my case here, and I'm, open to take the questions from the panelists.
Wonderful, Dr. Shubha. The expert panel, you have questions to ask?
Hi, Shubhra.
Yeah, Milind.
Shubhra, Milind here. Have you seen this happening with patients who have borderline thyroid disorders also?
Like, I'm a hypothyroid patient. I'm a frank hypothyroid patient. It happened to me, but not necessarily. I think it could be because, finally it is a T cell mediated CD4 related, it's an immune reaction which is happening. The first girl who developed this reaction actually had iridocyclitis in past. So iridocyclitis was present in this lady, which was not looked upon. And, usually when we are giving fillers, we don't ask such history of uveitis, iridocyclitis, or any kind of immune-generated reactions in the body, which was also a take-home or a learning experience for me, that we need to have these histories in place, apart from thyroid or any other disorders, or even, the autoimmune disorders, for example. We know that autoimmune disorders are relative contraindications for dermal fillers, but something like as trivial as iritis, which I wouldn't, we never ask such questions, is important to take, very, very important to take. And later I found out that she also had some issues with her, so she had generalized autoimmune reactions happening in her body sooner or later, like, in some form or the other. So yes, to your question, thyroid could be related. There is no proven data for it right now. But yes, if you are having thyroid or even diabetes for that matter, I think patients are prone for delayed hypersensitivity reactions. But what I have seen most often is it depends upon the technology, the Vycross versus the Hyalocross technology, which is more differentiating. So I haven't seen as much delayed hypersensitivity reactions with Hyalocross as I have seen with Vycross. So that is what is happening. I think that is what we are looking at. And yeah, I think that's what I want to say about this.
Well, I've seen occasionally that these patients, when you do a BLEF, if they've received a filler earlier and when you do a BLEF, their response, tissue response, can be more than normal. So I'm guessing that these things continue and trickle down years after the filler is in.
Yes, in fact, I saw a very interesting case, and I think Francesco had also presented it, that, if you are giving periocular fillers, especially the tear trough, not even periocular, if anything in the upper part or the mid face, if it is given, you can have patients coming back after 4 to 5 years with sausage-like deformities along the upper lid and the lower lid, which can be present. So yes, I think what we are looking at is a delayed hypersensitivity reaction, or a retention of a filler in a very strange manner, even after 5 to 6 years of the filler being given, even though it was minimal amount which was given, because none of us are going to inject huge amount of fillers in these areas anyways.
But the one you did for me is doing well. I'm fine.
I'm glad. Thank you. I'm forward for
I
that.
have a question for Milind and Shubhra.
I think we should move on, because there are 2 more speakers. Sorry, very sorry, Dr. Lakshmi. Maybe we can take that question in the end. Satyajit, could you introduce the next speaker? Dr. Satyajit?
Ma'am, you have the details.
The next speaker, second to follow, is Dr. Tarjani Vivek Dave. And Dr. Tarjani is an ophthalmic plastic surgeon at LVPI with keen interest in orbit and socket surgeries, with awards and attributes for a novel work on thermal imaging in thyroid eye disease, and is a leading force in introducing 3D printing for customized implants in oculoplasty, besides her other major contributions. On to you, Dr. Tarjani.
Ma'am, I want to take 1 minute to introduce her as the daughter of one of the most famous ophthalmologists, Dr. Yogesh Shah from Mumbai, who was the treasurer of AIOS earlier. What an honor it is to welcome her to this ARC session. Welcome, Dr. Tarjani.
Thank you so much. It's such a huge privilege to be recognized for your genes. But thank you so much, Dr. Chitra, Dr. Satyajit, Shruti, who's been silent but has been juggling a lot of things together, and the entire ARC panel. I'm going to discuss this case of a 15-year-old girl who came to me from Calcutta, seeking care for making her look normal. I am Tarjani Dave. I work at LV Prasad, and the most challenging case that I have selected today is a venolymphatic malformation that I treated with multimodal management. I do not have any financial disclosures to make, and you're going to see full face photographs of my patients, consent for which has been obtained. Lymphatic malformations, as we all know, can affect the conjunctiva, the eyelid, the orbit, or it could be a combined presentation. These are usually benign vascular lesions that are very ill-defined, and hence dissecting them or debulking them becomes difficult. They generally have very low or no flow, which means they're not connected to the systemic circulation and hence are safe in dissecting. And usually the treatment for these goes in terms of sclerotherapy or some form of multimodal management. So I'm going to discuss with you the lessons that I learned through 10 points. So I asked her when she came to me for her old pictures, and she had been carrying all the photographs with her, though not of great quality, but you can see that since childhood, the left eye seems a little prominent, and maybe when she was about a year and a half old, you see the upper and the lower eyelid nodules developing, which progressed to the state as you are seeing when she presented to me, where she had a conjunctival component, an eyelid component in the upper as well as lower eyelid, and a definite orbital component by the benign lymphatic malformation. And her major concern was she wanted to look normal because she had been having this concern even with wearing glasses. Sunglasses was difficult because she had a proptosis of almost 10 millimeters. It was difficult for her to go outside the house without getting stares from people. On examination, everything was normal. She had good vision. As far as the anterior segment and posterior segment is concerned, things were normal. There were some choroidal folds at the posterior pole. External examination wise, you see the gross proptosis and you see the conjunctival component in the inferomedial, superomedial, as well as the superolateral quadrants. This is a slit lamp image showing the lymphatic vessels with bleed within it. This is typically known as lymphangioectasia. Obviously, for any orbital lesion, you go ahead and image the patient. Imaging modalities might differ. This girl went ahead with a CT orbit. And classically, venolymphatic malformations present as ill-defined lesions. They are everywhere in the orbit. They're intraconal, extraconal, preseptal, orbital. And they take the form of small cysts, which are known as microcysts, where I'm pointing, or sometimes they can be larger, which are known as macrocysts. Whenever you see cysts which are greater than 1 centimeter in diameter, they are termed as macrocysts. But the most striking feature is the size of the orbit. You see that the orbit is expanded on the left side, and that primarily is because this is a benign, long-standing lesion. She's been having this since she was a child. So obviously, due to the pressure from the tumor, the orbit has expanded on the left side. There are several treatment options for venolymphatic malformations. Currently, what is in vogue is sclerotherapy with one of the sclerosing agents. Bleomycin typically is an agent of choice because it helps you in both microcysts as well as macrocysts. There are several other sclerosins, but bleomycin is pretty inexpensive and easily available. You could also move on to treat the patients medically with certain tablets, especially propranolol and sirolimus have been used in lymphatic malformations. Or you could go ahead with one of the orbitotomies and debulk the lesion, or you could have multimodal treatment with all of these combined in a venolymphatic malformation. Bleomycin was initially used in pleural effusions to make the two layers of the pleura stick to each other with the detergent effect of bleomycin. And that's the similar concept that you want to use in a venolymphatic malformation, where you want to remove the fluid from the cyst and make the walls of the cyst sort of fuse with each other so that they cannot refill with the blood and reform the vascular malformation. It has some pulmonary toxicity, but generally doses used in the orbit never reach the pulmonary toxicity levels. And typically when you are giving sclerotherapy, you combine bleomycin with xylocaine. Now this is for the reason that xylocaine helps in dissolving the bonds between the septa of the lymphangiomatous tissue. So no matter where you've injected bleomycin, you'll help it go all across the lesion if you've added xylocaine during your injection procedure. So we went ahead with planned sclerotherapy for her. This is her on presentation. This is her after the first injection of sclerotherapy, second injection, third injection, and the fourth injection of sclerotherapy. And I was pretty happy at the end of it to see that the entire conjunctival component had regressed. You can see hyperpigmentation of the eyelids, but this is transient. It's due to bleomycin. It tends to go away after about 6 months. So I was pretty happy at the end of it and thought this would be the end of treatment. And she looks pretty normal compared to what we started with. So how do you determine whether you have completely treated the patient or not? You go ahead and scan the patient. And when you scan, you'll see that you have a reduction in the size of the tumor. Remember that the tumor cannot disappear here because you're not debulking it. You're only shrinking the tumor with the help of a sclerosant. So your end point for treatment is always clinical. You look at reduction in proptosis and you look at regression of the lesion to determine whether you've reached your end point or not. And until then, you can keep giving monthly injections of sclerotherapy. Radiology helps you in figuring out where are the cysts, which is the area you should target, and whether you need to go ahead with further treatment or not. So here, if you compare the pre-scans on the left with the post-scans on the right, you'd see that the proptosis has significantly reduced, and you see some fat spaces within the orbit in the post-scans, which were not visible in the pre-scans, which means that the tumor is now shrinking in size. And this is what we also published. So we looked at endpoint of treatment by imaging all the patients that we treated with bleomycin sclerotherapy, and came to the conclusion that your endpoint should always be clinical and not radiological. So this is her at presentation, and this is her after the treatment. But then this was the end of treatment for me. However, for her, the goalpost changed. She complained about the hypoglobus that was still persistent on the left side. And that is bound to happen because that orbit is expanded. It's much larger, as we saw on the scan earlier. So she complained of residual hypoglobus and definitely wanted treatment for it. So what do you do now? If you insert an implant to correct the hypoglobus, you're going to have worsening of the proptosis. So you have to have a sort of graded treatment between sclerotherapy and debulking and a secondary implant at this stage. So what we decided was to insert a wedge implant on the floor. And in the same sitting, we debulk the tissue further so that she does not develop or does not have a worsening of her proptosis. And this is her after the Porex wedge implant that has been placed along the floor. You can see that the degree of hypoglobus has decreased. It's not completely resolved, but it's definitely decreased compared to her before the surgery. And these are her scans at presentation at the end of bleomycin sclerotherapy and after the wedge implant. If you look closely, you'll see the hypodense shadow of the Porex wedge implant, which has been placed along the floor of the orbit. Now, whenever you place additional implants in a sighted eye, you're always worried about motility. And in her case, she, to begin with, had restriction of -1 in all gazes. And that is what she maintained to have after the wedge implant. We did not see any worsening in the motility. However, what at times happens is a little bit of ptosis that can come in after you have introduced an implant. And that's exactly what happened in her. And her goalpost now changed from hypoglobus to the apparent eyelid asymmetry. We went ahead and did eyelid fold formation and attempted a little bit of ptosis correction. This is her post-operative picture. Due to COVID, she's not traveling at present, but has been kind enough to send her picture. Though the fold looks much better, there is some residual ptosis over there. There is improvement that can occur. But to me, this looks much better than what we started with. To summarize, orbital lymphatic malformations are difficult to treat, and they many times require a multidisciplinary approach. Sclerotherapy has promising results and a very limited side effect profile. The dose of sclerosant depends on the extent of the lesion. So does the sittings, number of sittings. The agent of choice depends on the availability at your center, as well as the side effect profile and your experience with sclerotherapy. Oral medications and targeted treatment do hold promise, but can take a very long time in getting the right outcome. So to answer her question, can you make me look normal? Well, multimodal treatment takes time, but the outcome can be sublime. Though not perfect, she was very happy, and she is a painter by profession. And this was her before the ptosis correction, where she was kind enough to make a portrait of mine and gift it to me before she left from the clinic. So a happy patient definitely makes for a happy doctor that should read. And this is me zonked after a long OR, so excuse me for that. Just a couple of slides where we have published our results not only in orbital but also in peripunctal lesions, and we currently have the largest series of bleomycin under review. Thank you so much for your attention. I'd be happy to take any questions.
Amazing presentation, Tarjini. Expert panel, you could give one question before we go on to our last speaker, because I think we are running late.
I think that Dr. Chitra, can I have a question for her? Yeah, I think very, very beautifully documented and very nice presentation, Tarjini, on what is obviously a very challenging condition. The only thing is, if you look at it not from an oculoplastic point of view, but from a layman point of view, the pigmentation of the lower lid, or the way the lower lid appears more darkly pigmented, is again a finding that you would need to address. So how do you plan to do that?
So that's an excellent question, sir. And what happens is skin does not have bleomycin dehydrogenase. It does not have the enzyme to break down bleomycin, and hence bleomycin tends to accumulate in the skin. It over a period of time is washed out as the half-life of the drug reduces. So this is a transient feature. It stays for about say 6 to 7 months, and then definitely goes down over a period of time. So to begin with, if you would have seen her eyelid, it was involved with tumor, and tumor looks blue. At the end of treatment, it looked a little blackish, so she was not really concerned about it. But 6 months down the line, the latest photograph shows that the pigmentation has near completely resolved. So you need to explain to your patients that this is something that is going to take time, and it will go down over a period.
Yeah, thank you.
Thank you very much, Doctor. We shall now go on to our last speaker, Dr. Raguraj Hegde, who is going to be bringing in the best in this very eventful webinar. Dr. Raguraj is a consultant orbit ophthalmic plastic surgeon and ophthalmic oncology and services in the Department of Ophthalmology in Manipal Hospitals, Bangalore, and is also an adjunct faculty in the Department of Ophthalmology in Kempegowda Institute of Medical Sciences, Bangalore. On to you, Doctor.
Can you hear me?
Yes.
Yeah, thank you for the opportunity to the AIOS-ARC team. It's my privilege to be presenting today. I am to present my most difficult case. It's titled A Broken Eye, a Broken Face, and Lots of Tears. By the end of the presentation, I hope you will know why it is titled as such. The story starts in March 2019. I was called for an urgent consult for a road traffic accident where the patient was still in the ICU and while he was being intubated. I examined the eyes, and I suspected there's something wrong with the eye. On examination, it was looking fine, and it was a self-filling corneal laceration was there from 12 o'clock to 5 o'clock. It was diagnosed by Speeders positive, though it was self-sealed. So it also on CT scan, he had a Lifford 1 fracture, left orbital zygomatic fracture, a left orbital fracture, orbital floor fracture, inferior orbital rim, multiple fractures, which included the nasal bones as well, a mid-palatine fractures with migration of the upper alveolus superiorly, and the mandibular fractures as well. So immediately, because of the corneal laceration, and there was no cornea surgeon present at that time. So I wanted to operate on it and did a corneal laceration using the 10-0 nylon and 8-0 vicryl on an urgent basis. And basically at that point of time, I was present. And later on, when the patient was stabilized, the patient was later taken up for primary reconstruction by the plastic surgery team. I was not involved in this particular surgery. After that, he had multiple orthopedic surgeries over the next few weeks. The patient spent a total of about 45 days in the ICU and another 6 months in rehabilitation to get back to his. The patient was lost to follow-up during the 6 months of rehabilitation. I had not seen him. He finally presented about about 6 months later, about in October 2019, with a chronic dacrocystitis. That was his main concern at that point of time. His left eye vision was 3/60, which is obviously due to the corneal scar post laceration repair. And he had a left eye inophthalmos as well as a restriction of eye movements superiorly. Other clinical findings was a loss of left malar prominence, a loss of bite on both sides. Only one tooth was able to make contact with the lower jaw, and a left zygomatic arch prominence also. On a CT scan, it confirmed all our clinical findings. We can see that the orbital rim of the left side is fractured, and the nasal bone as well as the zygoma is not properly reduced. And the maxillary sinus was obliterated on both sides, left more than the right, because the superior fixation of the upper alveolus. And the orbital floor fracture also was there.
मैडम कल कॉल कीजिए, अभी रात हो चुकी है.
So there were a lot of moving parts in this patient. So a lot of issues also going on. So the easiest and the lowest hanging fruit was the chronic dacrocystitis, which was treated with endoscopic endovasal septoplasty, and dacrocystic rhinostomy was done at the same sitting. We did it immediately after that, and we intubated the ostium so that it would help us during the reconstruction later with planning. The next step was the secondary reconstruction of the face. So for that, we got a 3D printed stereolithographic models printed so that we could plan adequately and what were the things that we needed to do. At the same time, I also had to assemble a team to take care of the various issues with the reconstruction. So I teamed up with the maxillofacial surgeon, who then suggested, seeing that the teeth alignment was wrong and it needed treatment as well. We also roped in a orthodontist by the treatment plan. So we did a virtual mock surgery using computer generated models and using computers to move the bones around and see at what, so that we can get the optimum outcome. So we decided on a proper optimum outcome using mirroring from the other side, which is relatively better than the left side. The mirroring of the right side to the left, and we could arrive at some semblance of symmetry. We got it 3D printed, the new model that we were hoping to achieve, and we used this as a surgical guide for our orbital implant, so that so that it would be easier for us to place the implant during the surgery. So at the same time, we also had to take care of the teeth because he was not able to bite. So the orthodontic treatment, because there was a palatine fracture, we had to plan the fracture reduction in such a way that it would be easier for the orthodontic treatment also after surgery. So we did the surgery in March 2020 this year. So about a year after his original injury. So we first had to remove all the plates that were put in by the earlier team, and we use a transconjunctival route to reach the orbital rim and the floor of the orbit. We used a pre-existing scar that was there for the frontozygomatic sutures, and then we removed the plates from there, and also we did a bioral incision from the oral side to remove all the plates that was valent. After that, we did took a bone graft from the iliac crest, and we used it as a strut to bridge the space between the orbits and the upper alveolus. So it acted as pillars to make the space between them. And after we did that, we reduced the zygoma to the proper place and fixed the orbital rim. Then we fixed the orbital floor fracture. And then we fixed all the other buttresses from the oral side. The post-operatively, there was orthodontic treatment that improve the teeth alignment, and the treatment is still ongoing. And how we were supposed to. This is the final plan. And post-operative CT scans were done, and we see that the zygoma is properly fixed, as well as the floor is properly reconstructed, as well as the rim is also done well. And 3D reconstruction of the implants of the pre and post surgery shows that we've achieved a relatively good symmetry on both sides, as well as we've increased the distance between the orbits and the upper alveolus, and even further orthodontic treatment is the teeth alignment also should improve over time. This is the post-operative clinical outcome. This is about 3 months out from surgery. We see that his alignment is, the inophtalmos is better, the zygoma is restored to the original place, and he doesn't have any restriction of movement at 3 months time. And this is a pre and post comparison where we can appreciate the reconstruction, the secondary reconstruction that we've done. He still has orthodontic treatment going on at present. So hopefully it should get much better in the next few months. He still has a nasal deformity, which we plan to take it up in a further sitting maybe next month. We decided not to tackle it at the secondary reconstruction because it was too many things were going on. And left eye also, we thought of rehabilitating using a contact lens trial with the cornea specialist. The best corrected vision improved from 3/60 to 6/36. And even though he has a little bit of hazy vision because of the central scarring, but there was no diplopia in any of the gazes. We are planning a penetrating keratoplasty next month. So the timeline of surgery was when he March last year when he had the accident. In October when he presented with the dacrocystitis, it was treated with the DCR, and then a secondary reconstruction at March 2020, and July we did the visual rehabilitation with partial success. So next month we are planning to do a rhinoplasty with some scar revision as well as a corneal transplant. So in conclusion, the primary repair is the best chance at reconstruction. So a holistic approach to addressing various issues is important, and a secondary facial fracture repair gives a lot of headaches. It's quite painful for the patient as well as the surgeon. So detailed planning is required because there are a lot of moving parts and the bone volume loss of malleolated fractures. So, and it also for best outcomes, we need a very multidisciplinary teamwork with all members of the team understanding their own limitations. And
1 minute.
so I would like to acknowledge all the other surgeons who are involved in the care of this patient. So thank you very much for the opportunity.
That was
take any questions.
That was a terrific surgery, which we all saw. Anything to be asked by the expert panel?
Excellent, excellent. And I think the one big take home message is multidisciplinary approach in this particular scenario. And I think that's been well carried out. Thank you so much, Dr. Ragaraj.
Thank you.
Yeah, that was a wonderful presentation. So I think we've come to the end of the webinar, and it calls for a very huge thanks to one and all of you. Every single person in this awe-inspiring faculty, the expert panel, you have made it such a remembered webinar. Special thanks to the admin team of AIOS led by Mr. Kripal. A thanks to Mr. Sunil, who was in webinar in charge. My very special thanks to Mr. Sai and Manjula, who have always been backup for us. A thanks to our sponsor, the Entod Pharma, who have backed every single venture of ARC. And of course, my very special thanks to my very endearing ARC team. And most importantly, I think we need to thank all attendees for their encouragement and participation, which is how each of these webinars continue to be a success. Thank you, one and all of you.
Thanks, thank you so much. It has been an excellent meeting. And I think lots of messages for all of us. Everybody has learned a lot from this. Thank you so much. Shruti, thanks to you. Dr. Satyajit, been very patient. And all the panelists, really good, everybody's been pitching in and with a lot of minds for all of it.
Yes. Shruti,
Thank you, everyone.
We should have
Thank you.
made a special note of that, Shruti, and thank you so
Thanks
much.
to Vidya,
And
who's very quietly was organized a lot of things.
And also Shruti and Dr. Chitra, thank you for finishing on time, because like airlines, on time means 15-20 minutes without that. That's fine. Okay. So that's well within